Hello, everyone. I'm in live now. Hello, hello, hello.
हेलो।
Nikita ji, I'm in a YouTube live now.
हाँ।
Please inform them actually because nobody is there.
सर काय अडचण नाही, पण आम्ही महायुती मानणारे लोक आहोत. कारण
Not audible, sir.
to take extra care and find out the things. This is the integral part. We cover them with all the elements, all the investigations, civil investigations, and find out the babies which are going to be sick. Then comes intrapartum period. Now, when as far as freedom, three things, the three types of mortality which can be prevented by this program is preterm births, preterm births and preterm babies. Second, birth asphyxias, and third is infections during pregnancy or intrapartum period. So you have to take full care. They've asked about the challenges during steroids for preterm babies. So here we have those controversial period when patient is having altered gestational altered glucose tolerance, and we have to give a steroid. This is one of the challenge we think over. We have to adjust the dose. Sometimes we hospitalize the patient. We give her first dose, monitor her sugars, her FHS, I mean fetal monitoring, and then we give a second dose, and then we send her and we call her after giving her a tocolysis. As someone has asked, tocolysis are the drugs which are given to, soften her uterine contractions. So these are challenges with steroids. And secondly, they require two doses. So they have to come again. So that is again a challenge talking about the patient. Many times they don't come in spite of hammering them that they have to take the second dose. So we have to advise them to take at their respective places. But they should take two doses of steroids before 34 weeks as advised by NICE guidelines. Now, after in intrapartum period, because pediatricians are there along with us for every high-risk patients, so the part which we have to do is we have to have a very gentle delivery of the baby, very good handling, deferred cord clamping and handling the baby in a warm congenital atmosphere. The care which can be given in post delivery and to the patient is many places. We generally talk about big institutes. Institutes are well versed with all the facilities. But when we talk about a small nursing home, we talk about a periphery where these high-risk babies are born. So we have, as a proxy and IAP, we have to give minimum basic guidelines ki what all is must. They should have a very clean place to receive the baby. They should have warm environment. All the paramedics and the staff should be again and again counseled and again trained to have aseptic practices, so which can prevent infections and can improve somehow the outcome of the babies.
I am in NHM program in Government of India. The Dexa is given 4 doses. She's telling, I think, private sector giving betamethasone, but Dexa is 4 doses to be given, and that is one thing. Yes. Yeah. In government sector, I am from a government sector hospital, so Dexa is recommended in the NHM program. So 4 doses should be completed before at least the labor has started or labor completed, and that is very rare. What thing we should think of, that counseling the mothers, what the obstetricians can do, that mothers who may have preterm labor, they should be counseled and they should have the access to the medicine. At least we can write in consultation, OPD consultation, that this medicine to be given if sudden labor pain starts. And you can tell anybody in your local doctors, local any hospitals, small hospitals or small nursing homes, and you can take this, at least start this injection and before you come to the main delivery point. I think awareness is very less among the mothers because the cost of surfactant, as I'm a neonatologist, and we in the government sector, we have crunch of CPAPs and surfactants. And also often the medical officers who are working in SNCUs, they will tell that I am not very conversant with LISA method, will not give surfactant. So all these specialized thing comes, and if the DEXA is given, even a 1 kg baby, we have normally delivered after DEXA with minimum respiratory distress. Even the Silverman score is not going up to 3 or 4 and only can be managed with simple HHFNC or CPAP without surfactant. So the cost of DEXA and surfactant is huge difference. So the DEXA needs maximum promotion, I think, on the antenatal period, and that can be done by the obstetricians. And when they are facing the patients who may give preterm labor, universal counseling should be done that this cheap from nearby hospital or doctor, and if you start taking and then come to the hospital, we will finish the course, and after the delivery then your baby will be fine and will be much better regarding lung condition. So this counseling, I think, much more word from the obstetric side.
May I? Well, to be very short, it's a very fortunate, I should say, event that we have both IAP and Foxy and UNICEF together, because the conception and the delivery and subsequently neonate, these are all continuity. Therefore, we need integration. And if we want to do any programmatic mode, then we must have this starting during the conception when the baby is, I mean, the mother is with the obstetrician. They respects and obeys the clinician most. So the obstetrician's role is supreme there, and then gradually it gets transferred to pediatrician. So there should be some link between these two through some agencies if we want to take it in, say, programmatic mode to make it a success. To every mother, empowerment, what Dr. Pashupati has mentioned, empowerment of mother is very important. And most important empowerment can come from the obstetrician, and then, of course, to the pediatrician. That not only this, but also even in subsequent points, I'll mention that this integration is very important. Why we are not getting successful in spite of the mothers are in health contacts, but we are not able to reach the better level, and even to in breastfeeding and all other parameters, we are not improving because of some lack of integration. That is, I want to stress here.
Here, as we are asking, how can we do IAP and Foxy integration? So, like we have ANC checkup, some guidelines should come कि the couple should be introduced to the treating pediatrician as well. No, this is very important when the baby is very sick and they are just, the couple or the family is just prepared to receive a baby. They are not forcing, or that baby may have some problem and he may require an ICU care, or baby may require some shifting or some care. So they should be introduced to the pediatricians. So it makes a easy, swift postnatal period for the especially sick babies that we can add into an antenatal program.
So, yes, Dr. Ramil, if you want to say.
So one more regarding the importance of iron folic acid as well as anti-diabetic. It should be propagated through the social media, then as well as in the school education programs. Right.
Point very well taken. So, I just want to, before moving to the second questions, just give me. Just want to add, we have to also think that many times we have our rural population which is not actually reaching to the specialist. They have been addressed by the frontline workers, the ANMs or the staff nurses who are working in government setting. So, I mean, we have to think in the government system, we already have certain training programs where we can think about having a partnership, how to monitor that, the quality of that training, how to ensure that the message that actually we were discussing here is actually getting translated and it's reaching to the right person. So now looking at the time constraint, we will take all questions once we get all our panelists done. Reaching to second question. Yeah.
So let him participate. We know enough, adequate. You hardly add anything.
Yeah, please.
I want to say that.
Yeah.
Can you get a mic?
Please. There.
We have proposed to Maharashtra government that when a girl marries, she gets a gift from the government, a pouch. This pouch will have one iron vessel. It will give iron to the whole family. 75 years of world experience tells And India's iron experience tells tablets don't work. They have not worked in 75 years. But iron cooking pot gives iron to the family and the mother. One, we asked them to add 16 milligram dexamethasone, 2 tablets. There are 4 milligram tablets, then 2 sets. So that when a woman feels that she's giving birth to a premature baby, she takes it because it's always late to reach the center. Yesterday, a baby was born in my place before the obstetrician. My colleague would give external. And in Maharashtra and in India, majority babies are not born in private. They are born in government, and they have a very miserable record of giving dexamethasone. In my district, it is not given in the government sector, and we are not aware of all this. So we have suggested that 12 milligrams of injection dexamethasone is equal to 16 milligrams of tablets. So give them tablets in that. Then we have proposed them that you give, I'm going to give you a packet. Give a packet of instant coffee. This has got 30 milligrams of caffeine. Suppose she is going to deliver in 7 months. She takes coffee or tea 3 or 4 times. Then she has some caffeine that goes to the baby. And babies are born and they die or because they do not get caffeine injection. 2024, my district place, caffeine is often not available. So we use this. You dissolve this in 3 ml of mother's milk or water. It gives 30 milligram of caffeine. You give 20 milligrams or whatever your dose is. Suppose the baby is 2 kilos. So if you don't know it, take at 2 kilos or give. So dissolve in 3 ml. Take out 2 ml. That gives 20 milligrams on day 1 and every day half of that. Fresh limit 2 rupees. Caffeine injection is 500. So this we are doing at the government level. I just wanted to share. I was sure I wanted to ask him a question, but there is no time for audience.
No.
I'm telling you 70-year experience. We don't have time for audience. But you speak because we come here.
Would you like to ask the second question?
Yeah, so Dr. Prashant, can you respond that how enteral feeding can be ensured in very small, sick and newborn babies? And what are the challenges in establishing these units in terms of infrastructure, HR training, and how we can support it?
Now, the question is, first of all, you need a definition of when you say small and sick newborn. Small means how small? Is it an extremely low birth weight or a very low birth weight? Because the approach will be totally different based on the definition of those babies. Now, if you are talking about extremely low birth weight infants, like less than 1,000 grams, definitely there's a different ballgame. That's not something which everybody can take care of. So if I understand that you are trying to talk about babies above 1,500 grams, when you mean small babies. Now, basically, one of the major things was in these things is there are few things. One is infrastructure. Second is human resource. And in the infrastructure, nowadays, I think the government funding is quite significant for all the government hospitals, at least in Karnataka, we are saying. And in Tamil Nadu also, we have seen that the government NICUs in Tamil Nadu are doing a wonderful work. And many of the district places are also having DM neonatologists who are doing a fantastic work. But the same does not happen all over the country. Still, we have many of the other states where even the basic facilities are not available. So first is infrastructure. So first thing is we need to put the infrastructure in place. And for that, we need the government training. I mean, the government involvement for that. Second is human resource. Human resources, one is doctor, other one is nurses. Both are become a very sparse commodity to get nowadays, and especially in remote areas. So now how are we going to fix that gap? So that will be again by training. You can't have a neonatologist in all the district places and taluka places. So you have to train your primary care physician only for taking care of these things. Rather than that, the best method to address this issue would be to have regional centers of neonatal intensive care units, that is at a district level, and have a strong and robust transport system. So where the babies are referred with a proper neonatal training of neonatal transport, where the babies are referred to the district hospitals, which has got minimum of level 3 tertiary care. So that is the one way how you can fix this gap. So it is practically impossible to have a neonatologist in every place. So it's always this having a robust system of neonatal transport. That again, even with the sake of repetition, I would like to say that the one model which we can all follow is what is being followed in Tamil Nadu. Tamil Nadu has got an excellent neonatal transport system which has been developed, especially with IIT Madras. So they are doing, I mean, most of the babies which are delivered in smaller places, I think we have Tamil Selvan. He'll be able to tell us more about the Tamil Nadu model, and which is being transferred to the district hospitals, and that is how you can, the infrastructure part and the human resources part can be taken.
Yeah, Dr. Prashant, you are right. Where Tamil Nadu model, where it's working, is okay, but the burden of neonatal mortality comes from states where these systems are not there. So probably we are looking how to develop that. Just like in West Bengal, I think Dr. Vasudev can come in also here. We had a lack of course, neonatologists and all that. But they trained, I think, just ordinary MBBS after passing out, and they are doing a great job in the SNCUs all over the network, and there it can have an effect. I would request Dr. Ramesh to put in of the situation in Rajasthan, scenario in Rajasthan. Yeah. So, Mike.
In Rajasthan, SNCUs are mainly made by pediatricians, and they are being supplemented or helped by the MBS, and they are being trained in the FDNC module run by the government, along with the FDNC module that covers the basic concept care of neonatal care, plus CPAP, oxygen therapy with lactation rate. We are giving them regular training on these modules, and few of the centers are really doing good.
Sure.
I think CLMC. So, but can I reframe this question exactly? So what we have seen is happening is there is a lot of use of IV fluids in SNCU. We are the utilization of I have this.
So what is happening is there is a lot of use of IV fluids rather than using the expressed milk or the mother's milk. And this question is more regarding, I mean, what is the gap there? Is there a training issue, or there is a need of infrastructure issue? Because what we have seen in many states, we still don't have the LMUs and CLMCs, because CLMCs also require a lot of infrastructure, a lot of space for having the equipments for doing the pasteurization and the maintenance of donor milk. So CLMC is not there in many places, and for having a CLMC, the footfall has to be good enough in the hospital. So CLMC is maybe possible in certain medical college who have a huge footfall, but LMU is something which even in NHM government is proposing to have at least LMU, though it is gradually coming into the picture. So my question is, as a pediatrician, how can we ensure that and there will be more work around the nurturing care? Now, before actually coming to Dr. Chaudhary, let me ask Dr. Sukant, because this question was initially meant for him. Sir.
Actually, to start with, I must take the first one. So after so many decades or even centuries, we are yet at the level of, say, 42% only for the successful initiation of breastfeeding. So why we are at that level? And more, the mothers are coming in health contact probably lesser they are having successful breastfeeding, considering the ancient days. So I give more stress in my experience of so many years in practice. The mothers are having two issues. Some of them are not aware that what is the advantage of breastfeeding, but many of them are aware. Second thing, many of them feel that the milk has not come yet. So their empowerment of the mother is very important. I've even seen the mother considering that the breast is not fit for the baby to suck. The nipple is not adequate, it's hard enough, and all that. So all those issues could be addressed by the tie-up with obstetricians and pediatricians in the antenatal care and the immediate after delivery, that any form of breast, even if it is a flat nipple, then that is also possible, and you are competent enough to feed your baby. Think of a tiger. What the tiger will feed to his baby if there is no milk. So these sort of examples empowers her, and she is very eager. But baby is crying, so somebody else is saying that give some formula feeding and all that, so baby stops, so mother is satisfied. So this is empowerment of mother, that is very important, and that is really a break point. If we can break this, then only the mother is successful. A small amount is enough. That is initiation. And subsequently, successful breastfeeding again, initially mother feels that the breast is tight enough, the milk overflows because the milk storage lactobacillus tubes are not yet dilated, like say balloons. So subsequently, when they go back home, the milk storage increases and the milk doesn't flow out. So mother thinks the milk is less. So the mother is again going to the formula feeding with the say advice of the grandmothers and all that. So all these issues could be told to her when they are in contact with health facility during delivery. That will make a break point. And another thing is the advantage of formula feeding and the mother's milk. The advantage, if the mother is not aware regarding particularly the adult type, the prevention of NCDs and the cognitive performance of the baby, all these issues would be very attractive, and that is also based on science that we can definitely promote to the mother, and mother will do the best to make successful breastfeeding. So these are issues. And one example I still remember, the artificial feeding or the formula feeding. One baby used to take goat's milk. That's there in the rural area. The goat's milk is considered very nutritious to the baby. No. So I said to the mother that don't give goat's milk, give your own milk. Then the grandmother accompanying, she said that you are advising against goat's milk. Gandhiji, the father of nation, took goat's milk, and you are advising my grandson to stop it. So imagine the potentiality of strength of this statement, that she sees the potentiality of Gandhiji in the grandson. So I have to counter it also, not by science, but by saying that, well, you are right. But Gandhiji took goat's milk when he became Gandhiji, not in the neonatal period. So then she got convinced. And then the mother also allowed to take the mother's milk, and then it becomes successful. So these are breakpoints that the mother-in-laws, the communities, and the mother herself, and mother herself can be taken care by the obstetrician when they are under her care or their care for the first 10 months, and then the pediatrician who are taking care in the facility itself. So this could help take this level. Regarding the next point, yes, any interaction?
Do you think, breast milk ban can issue,
As I manage small babies in government NICUs and SNCUs, that often we think we have seen, at least I can tell you that I have saved a 1 kilo baby without any prick. That was 33, 34 weeks, and fluid was not given at all. It is totally on mother's milk. And I was scared not to give any formula milk, and I have not given. And obviously, I am not supposed to give other mother milk. That is unethical, I know. But in some situations, for saving the baby, we have to do that. But actually in West Bengal, there is only one breast milk bank, and that is also in SS scheme. We don't have access, but I think if we have the access for breast milk in small babies who are born, even 28, 29, 30 weekers, there is no need of prick most of the time. If they have received antenatal steroid, they may need 1 or 2 liters of oxygen for 1 or 2 days with some tube feeds, and katori spoon feed is enough. But formula milk is not tolerated most of the time, and breast milk can do the miracle by avoiding prick, avoiding antibiotics, avoiding antibiotic resistance. And I think as OBM ethically should not be used, so breast milk bank is answer to it. And it is easier to teach the medical officers who are MBBS only and working in SNCUs by ABNCs that nothing is required. You just give the milk only by tube feeds. And I think this is one of the way to decrease the antibiotic resistance also. I don't know why breast milk bank are so less in most of the places, and mother's milk feeding in small preterm can do a miracle if it is
So,
given from
what I want
birth.
to add as obstetrician is breast milk is of course the elixir. Yeah. Yeah.
Towards you
But
tried.
we at our end, what problems we face, I tell you, breast milk should be immediately initiated breastfeeding, but many time it doesn't establish. The patient is struggling. The patient may be a normal delivery patient or a patient is post-section patient. Immediately we try to put the baby to the breast. Baby crawls up and it takes up. That is the best, most beautiful moment for us, for the family, for the mother. But many times it doesn't establish for some other time, and secretions don't arise for 1 or 2 days, and that is the point where mothers start getting anxious. She is prepared ki once she deliver and she is going to get a flow of milk. So here is the catch point that we have to counsel the mothers that it's going to come, and one drop of that colostrum is so vital for that baby. This has to be inculcated in the patient that you have to put to the breast and give one drop. And many times we get, when the babies are shifted, we get messages from the pediatrician, send the breast milk. I really tell you here, it is impossible to send good quantum of breast milk on day 1 or day 2. And the mother and the relative, they are just dying hard to get the milk out. And it's a big fight between patient, ourselves, and the mother. And that stress, she's not getting milk, it hampers her secretion, her lactation, it leads to lactation failure. She becomes so anxious. She forgets her pain. Madam, doodh nahi aa raha, and then whole family is after it. So we have to look into it, how we can come up with this problem.
This issue.
Madam, they find excuse to start the no.
Yeah.
So,
Yeah, yeah, but
here we must break. Sir,
yeah.
here we must break, and by science, we must say that baby at this stage does not require
That
so
much.
much milk. That is important. That first 2-3 days, the fluid requirement is less. So if we talk by science to the mother and to the families, then they will ultimately get convinced. And secondly, yes, to the doctors,
Yeah,
those
that's what,
who do
because
not
we
know, sir,
have the
those who do not know.
experiments.
But many of us know, but we do not implement it. Secondly, one point more I want to just share that the mother is very eager. But as you said, the family members are stressing. The milk will not come. It takes time. So that is important. It will take. Yes.
She's not fed. Especially if it's an operative delivery, they are not fed. So the secretions come late. So they have to face a lot of problem. And as the age of mother is increasing, with more of stressful life, really it takes long for lactation to establish properly. It takes 5 to 6 days to have a proper lactation.
And the counseling should be started
Very
during pregnancy
And
itself,
we do that.
and including the female family members, which is not done. I think that is a very important issue, and the obstetrician should spend more time in examining the nipples and to counsel the mothers, including the grandparents
Normally,
of
everyone is nowadays putting it in our ANC
grandmother of both sides. And
Absolutely.
that only is the key to the success. If they are mobilized, grandmothers, नानी दादी mobilized है तो काम हो जाएगा. नानी दादी, बिना नानी दादी का कोई काम successful नहीं होगा.
Yeah. Excuse me, we are actually overshooting the time. Actually, our 45 minutes are already done. Be crisp and make it fast. My request to moderate.
Next question, please. Yes. So this is in continuation of the previous question to ma'am. The immediate KMC and the zero separation. Now government is more into the, I mean, they are also planning to change the old SNCUs into the MNCUs where mother and newborn can stay together. So how do you see this, I mean, aligning? And the second part is, what are the biggest challenge in scaling these MNCUs? So can we have a quick
Yeah.
words from you?
What we do, we just promote kangaroo mother care as soon as possible after the baby is stabilized. That was the rule so many, I think last 5 years. But nowadays the concept is coming that immediate and continuous kangaroo mother care in a mother newborn care unit. What will happen? The mother will be delivered and will be shifted to MNCU like this. This is a picture where the trial was done in Lady Hardinge in the WHO
Safdarjung.
study, Safdarjung,
Safdarjung.
Safdarjung. And there the mother bed and the NICU is in the same place. So mother will be shifted to the mother NICU soon, and the baby also will be shifted there, and there will be a surrogate female also if mother is unable to do, and there will be continuous kangaroo mother care. This is a new concept, and that is highly beneficial compared to the kangaroo mother care after the stabilization of the baby. What is the main difference? Here the stabilization is of the mother and baby, both are done after the kangaroo mother care was on started. Then next thing is continuous KMC, and the continuous KMC and the continuous presence of the mother inside the unit. In the unit, mother will do KMC, and that position, the level 2 NICU, the baby may get CPAP. The next picture, I think there the baby is getting CPAP with the mother, and there will be all facilities like giving IV fluid, oxygen, warmer, everything, and the KMC will be continuously done. In the study, what WHO funded multicentric study has shown that this will there is a drastic difference in the KMC hours. After stabilization KMC, where mother is coming into the unit and doing the KMC and going back in her place, in that case, the KMC average hours in hospital stay is only 3 to 5 hours, maybe 6 hours after quality improvement studies. But here it is around 16 hours, 16.9 to even 20 hours KMC is done continuously, and the mother is getting stabilized, baby also getting stabilized together. This is mother NICU, mother baby together, and this has a good success rate, decreasing the neonatal mortality even much better than the KMC, intermittent KMC or late onset KMC, and also high breastfeeding rate, decreased infection rate, less hypothermia, less hypoglycemia. So this study shows much better impact. But what is the problem here in scaling up in mother NICUs? No space constraint, then more instruments required. Suppose this type of rooms, one baby needs one warmer, one suction, one CPAP, everything will be ready for her. So this is a more costly NICUs and more costly maternal bed, because mother needs some places like latrine, food, all these things. So in these type of things also more costlier, and space constraint is there, and needs stakeholders like government, UNICEF, WHO, who will fund this. These are all new ideas. But if it is done, then definitely preterm low birth weight survival will increase. In our country, around 22% are preterm birth. Among the deaths, it is the 60%, even more. So if the death of the preterm babies or low birth weight babies are less, definitely the overall neonatal mortality is going to come down. So this is a very good approach, but it's more costly, needs more space, difficult to scale up in government setup. But if there is good wish is there and the fund is there, it is possible, and it is going to give benefit or in near future. Means if we start MNCUs in 1 or 2 months, there will be definitely decline in the neonatal mortality.
And just add 2 points. Thank you, madam. That was a very nice view of the mother newborn care unit. But this is not something new. Actually, this is a concept which has already been there, where family-oriented neonatal units were started in the Western world. And there even the ventilated babies along with the mother in a cubicle or even in rooms, individual rooms. And basic issue is again the space constraint and all this equipment and other thing. In our country, KMC definitely has a major role to play. And the positive effect of KMC is well proven. There's no doubt about it. Second thing is who should get KMC? The selection of babies will be very important. Now, just because KMC is helping, we cannot start KMC for every baby. So some policies have to be formed. Third is, again, in our country, even today, the maximum problem we are battling is the sepsis. Now we know our maternal hygienic conditions in many places, especially in the rural setup and in the semi-urban areas also. The hygiene standards are not the same as we expect them to be. And having such small babies with the mother, definitely there will be a risk for, and especially, no, that's why I said selection of babies. What gestation you want to do that. So there has to be some studies for that.
So basically
There
what
needs to be some studies for that.
basically what we need to do is we need to understand and do some more extensive research work on it and set certain criteria, certain indications, and certain contraindication that will eventually come. But let's start with having this KMC. If not all beds, at least start with 1 or 2 beds where mother and baby can stay together. Once we have that enough space, we can expand it to the entire unit. Now, ma'am, requesting you to just give just a brief comment on that before we moving to the last question.
Yeah, this study was done in 1 kg to 1.7 kgs and in poor countries only. So in India also one of them. Then so it is possible, number one, and it is proved that it decreases sepsis. And all where KMC decreases sepsis, it is proved because that less handling by other people and the maternal flora definitely not going to infect the baby because the antibodies are there in the breast milk. The KMC increases breast milk and breastfeeding rate drastically, and this increase in breastfeeding and breast milk containing antibody of all the flora mother is having is not certainly not going to increase the sepsis rate in newborn who is doing KMC in our poor mothers.
To get it, Dr. Bhashwati is very passionate about KMC. But Dr. Selvan, I think JIPMER also is really doing the KMC, as a whole. Because when you went there last month, yeah, they are fully implemented.
We have no doubts about the benefits of KMC.
Only how to do it.
What we are trying to tell is you need to formulate a policy
Right,
regarding
right.
the selection of babies. It's not that every baby can be started with this. They kept next to the.
This study was done up to 1700 gram. We can make it 2.5 in our country. It's not
No,
bad.
No, the suggestion what we are saying is we need to make a policy. So KMC is agreed, but to KMC for KMC there is a policy.
Nowhere KMC will increase sepsis rate. Even coconut oil application along with KMC is more weight gain, less sepsis.
Madam, all those interventions we are aware. Now this is a new concept where you want to not only do the KMC, keep
Let
the
mother
baby
in.
along with the
Right,
mother.
right.
There I am telling.
Next,
There you need
Yeah,
to make
that
some
is
selection
KMC,
criteria.
keeping the baby with mother, and
That's
mother
what
is
for that
actively
you need
involved.
to have some selection criteria.
Saji, can you have the next slides?
ये
Thank-
बहुत safe है डरना क्या
No,
है?
it is safe, but still some policy has
Oh,
to be
this
done.
was the CPAP that you had shown in the last.
Go to the presentation, the question and answer. The last question to Dr. Tamil was more on how can we ensure the judicious use of oxygen and the utilization of CPAP in units. And the second is regarding the transport. The transportation of sick newborn we had already discussed in our first question. Over to Dr. Sullivan.
Yeah, it's working. Not working. It's working on. There's light and so.
Always we have to remember oxygen is a drug. So it should be indicated only when there is an indication for starting the oxygen therapy. So training should be done at all the healthcare levels regarding the when to stop the oxygen therapy. Again, CPAP also, uh, early use of CPAP want to be other intervention can be like use of ventilator can be reduced whenever the baby is with respiratory distress is more, we can use the CPAP. Again, here also training is very essential for all the healthcare workers, so so that they will be more versatile.
So more of an oxygen audit.
Yes, yeah, frequent auditing also very essential.
But we are trigger happy, we are also oxygen happy. So the moment a baby moves into the NICU, the old training
They
was
will
that
start immediately oxygen.
So we have to
only
stop
it
that.
should be started when there is a indication.
Here, one point I would like to add, is oxygen especially. When we did the NNF accreditation also, we included that in the NNF accreditation few years back, that blenders are very important in the NICU. Most of the places, they don't use blenders. So just giving 1 liter, 2 liter, just subjectively is one of the major reasons why you develop ROP and other complications of oxygen. So first of all, it should be made mandatory that there is a blender for delivery of oxygen. And when they are buying a CPAP machine, most of them, they buy pulse oximeter. Yeah, more than pulse oximeter, the delivery itself should be controlled. The delivery itself should be controlled. Without a blender, you are just blindly giving.
So both, I think this both public and private sector, plus this Foxy IAP, they can help in procuring more of pulse oximeter and blenders at the peripheral level.
The only best way to do is when the NICUs undergo the accreditation. So that is the best way of maintaining standard or in maintaining a quality. So because in the NNF accreditation, it comes in the tick list that we should have a blender, how many blenders, where all blenders has to be there, all those things are there. So that has to be implemented in all the SNCs.
So why only NICU? Even in labor rooms, we can add, so
even-
the admission
no,
to NICU can come.
No, at the place of resuscitation, it is mandatory to have a blender.
Well, when we are talking about training of the staffs, regarding any quality of service, maintaining quality, the trained staff should be retained in that unit. That's also very important.
One more thing, sir.
In public system, public health system, that they are being transferred from this one to that one.
No, especially in government.
Purposes, they are for training purposes, no.
So especially in government setup, there is a usually after 6 months, after getting enough training, they will shift. So
That problem is universal problem.
Forward, that trained staff should be retained or fresh training should be added.
I think we have completed.
So we have one more question, but we are skipping because that question is more about the impact survival and we have already gone down the person.
The shifting of the staff, one very simple thing which can be done, we can make very good clear charts mandatory in each labor rooms. So where they are put up, if the staff changes, they know what should be the concentration, what should be the flow, and what should be the use of oxygen.
No, blender is the right way. It should be emphasized. And especially, see, most of the times, it is the pediatrician who gives the list of equipment which is required for a SNC when they're doing it. So they should be, insisting on putting blenders in their, whether it's a SNCO or a level 3. Blenders are all the things which has to be ordered for.
Can I tell about something about blender?
Yeah.
Blender costs lots of money. Use a venturi apparatus. You can give variable on this oxygen at 100. Talking about 80% deliveries happening at places where there are no. We are talking about places where less deliveries are made and less babies are made.
So even in the lowest SNCUs nowadays, we always, India has progressed a lot. We are always trying to cut short our this one. But standard and quality is equally important. Okay. Now what is happening is you are buying a CPAP machine from a multinational company, GE or a Dragger, paying 1.5 lakhs. Okay. The blender costs around 10 to 15,000. And when you buy along with the CPAP machine, no, that depends. No, there is a Brazilian blender, which comes below 20,000. And this, sorry, definitely, I'll send it to you. No problem, I'll send it.
So I think there's
No, you get wall mounted also.
where there is facility,
I'll send
there we can upgrade. Where there is no facilities, like doctor is saying, then we can even use the innovative ways that you are telling. That's also should be improved.
So see, regarding Vensuri तो अपने पास available है. That is just for mask.
Yes.
And for the unit, we need heated
Humidified interface, yes.
without unit. Just
एयर कहाँ से आ रहा है? We need airline for
Yeah.
CPAP.
No,
That's an important thing.
yeah.
We can use the connector. Or just
Yeah,
send the
T connectors we were using earlier, but nowadays blender has become mandatory. So it is, yeah. Government is giving so much of money, we are not utilizing in the state. Many of the states, they are sending the money back to the government without utilization. Yeah, even that is there. Yeah, even many of the research status are coming with blenders.
Don't have their own private sector. In fact, in SNCU and our medical colleges are better equipped. You don't see blender in private sectors, even with, so first is giving them an idea. that
Idea,
blender is
exactly.
required. Now, in medical college, I had a blender 25 years back.
Yes.
That time probably, very few.
Very few, yes, of course.
So we had it 25 years back. But today, in city of Mumbai, even in the best of the private centers, in obstetrics, in, mother OTs, you will not get a blender. So first, the knowledge of the healthcare workers that
Awareness.
blender is required. And then you find out, depending upon whatever is the thing that which blender. 25 years back, we had a blender of this, that time we had paid about 75.
It was costing more than a lakh.
That's what freedom necessity.
Now it has reduced.
People are not having it because they are not.
Okay, I think we'll move to the inauguration now. Yeah, it's a bit late.
Then without blender, we cannot resuscitate the data.
Okay, thank जोशी इनॉग्रेशन नहीं होगा तब
Patent file, published paper in the International Tropical Pediatrics Journal. Nebulizer does as good as a CPAP machine does. A fish tank motor, 150 rupees, does all that a 2 lakh rupees CPAP machine does. So just all use it where you have money, you are fine. If you don't have money, 80% pleasure, use it.
Thank you. So thank you all the panelists and Pramit for moderating the program. So we'll move to the inauguration now. Thank you.
Hello. Yeah. Thank you so much. Please have a seat, please. After we had that wonderful panel discussion on our first, the first panel, we will just go ahead with our inaugural session right now. And for that, I would like to invite Dr. Shati Sarma sir. Sir is a Senior Vice President, Central IAP. So please come and welcome for the welcome address, sir. Thank you.
Good morning, everyone.
I congratulate IAP Mumbai branch to organizing this UNICEF with IAP collaboration to reduce the neonatal mortality rate. And this is a workshop, and we have to calculate all these things. Every 1 minute, 6,000 newborn dies, I think. And globally, 2.6 million the newborn baby dies. So our target is to reduce the mortality to single digit by 2030. So we have gathered here to discuss how we can do it, what the innovation. First session, we have seen this. We have with us our National President, Dr. G.V. Baswaraja, who is online. I welcome Dr. Basant Khaladkar, sir, our President from 1st Jan 2025, sir. First Lady, Madam Pragati Khaladkar. Yes. Yeah. Our National Treasurer, Dr. Tanu Badra. Dr. Yogesh Parak, our Secretary General, is on the way. Sir. Dr. Tanu, sir, please. Then Dr. Shobna Gupta, ma'am, they are online. Dr. Vivek Pindra, Chief Health UNICEF India, is online. Dr. Sanjay Singh, CFO, UNICEF Office Maharashtra, online. And our Vice President 2025, Dr. Prashant Subodh. Our EB, Dr. Ramesh Chaudhary, Dr. Neil Patel, Dr. Suganta Chatterjee, Madam Ruchi, and Dr. Madam Archana, and all others. I welcome you to this workshop. And the main aims of the workshop, as discussed, to reduce the NMR to 1 digit by 2033. So welcome you all for this workshop. Thank you very much. To our local, this coordinator, Tanu Mukherjee, yes, madam. Yeah.
Dr. Baswaraja.
Yeah. Yeah. Now, Dr. Baswaraja, for his blessing and remarks for this inaugural ceremony of this workshop.
Thank you so much, Professor Satish Sharma ji, and our Honorable President of Indian Academy of Pediatrics, Dr. Vasant, and Treasurer, Dr. Tanubhadra, Dr. Yogesh Parikh, and Senior Vice President, Dr. Satish Sharma ji. We all know newborn care is one of the most essential component of our pediatric care. In that regard, newborn week celebration we have planned with a great support from a UNICEF team led by none other than Vivek Singh, Pramit Srivastava, who has been very instrumental in coordinating with all the organization, including POXI, which is represented by our Pragati Kalatkar madam. And UNICEF is always works in tandem with the Indian Academy of Pediatrics over years. And this year too, the team led by Vivek ji, Pramit Srivastava, Sanjay Singh ji, who has been very instrumental in supporting and collaborating with Indian Academy of Pediatrics. Of course, Government of India, which is one of the main thing in the newborn care, where the different program which has been rolled out for over years. In the 1992, Child Survival Safe Motherhood program has been launched. In the year 1997, RCH program. This is also focusing onto the newborn care. And of course, National Rural Health Mission, which is changed the whole scape of an pediatric and maternal care in the year 2005. And of course, later we have come out with the RMNCH plus adolescent care in the 2013. Now, the National Newborn Week, after this rolling out of a NHM program in the year 2014. That's the year where the whole landscape of health infrastructure which has been changed across the India. Now we are moving from Millennium Developmental Goal to the Sustainable Developmental Goal in the year 2016. That's the time Government of India had taken a very important step in the year 2014 India Newborn Action Plan, where Indian Academy of Pediatrics is working with Government of India, UNICEF, WHO to reduce the neonatal mortality and stillbirth to the single digit. Every year we are coming out with something new ideas, new thing, and that will help the care of a newborn. Simple measures of things like taking care of a neonatal resuscitation, where the Indian Academy of Pediatrics, which has been one of the flagship programs since the year 2009, where we have trained in more than 1,70,000 healthcare workers, not only the pediatrician, not only the obstetrician, not only the other healthcare worker like a nursing staff, and these people has been trained by the Indian Academy of Pediatrics. Our goal is to reach in a 3 lakh. That is the time where in the previous panel discussion, when Dr. Prashant was mentioning about we cannot expect a pediatrician to be there at each delivery. So it is our goal of Indian Academy of Pediatrics is not pediatrician. How do we empower our healthcare worker? It could be an obstetrician, it could be a general practitioner, it could be a pediatrician, it could be a nurse, where we can empower them to take care of a newborn. That measure itself can bring down the significant mortality. Second simple measures which can make a big difference is your taking care of in infection. Infection is one of the most important thing. Presently, almost 33% of the neonatal death in the first week, mainly because of an infection. How do we control this? How we create an awareness of prevention of infection and hygiene, and especially social media utilization in the present era, where the government use it effectively. How the organization like UNICEF, WHO, and Indian Academy of Pediatrics can play a role in creating awareness among the common people regarding the infection prevention. That's another important thing where it can make. And of course, in one of the program when you launched about the thing, now Pragati Madam is also here. How we can utilize the our obstetrician, how we can prevent the premature death, and even if the premature death, premature delivery occurs, as a pediatrician, as an involvement of an NNF, how we can prevent the premature death. That is a significant thing where we all can play. So when we can address these prematurity and complication during the birth and severe infection, and the fourth thing where we are involving a congenital malformation to address that, pediatric surgeons role is really going to play in a role. That is why we have certain appointment with the Ministry of Health and Family Welfare, how we can improve the newborn surgical care across the India, where we can congenital malformation is the other part of it, where we can bring it down. This is where the Indian Academy of Pediatrics can play in a bigger role in addressing all these things. And of course, this year theme of our newborn week, safety, quality, and nurturing care, is a birthright of a newborn, where Indian Academy of Pediatrics is the first professional organization in the world where the nurturing care has been in a part of our routine care. This is where in the year 2020, even though this came in 2016, no country has been adopted it, nurturing care. Indian Academy of Pediatrics came in 2019 with an early childhood development, where nurturing care that includes a newborn care also. And subsequently in the 2021, where we could be able to train 10,000 pediatricians conducting a 200 workshop. And this is the time where we can need to take it to the community and focusing on the newborn care in that also it is going to play an important role because first day, first week really going to play a big role. I am sure with the Dr. Vasantji is taking over from the 1st of January, the way we can more collaboration which is required with the UNICEF and NNF, POXI, where we can all work together and our goal is to reduce a single digit neonatal mortality and the stillbirth that way. And this is a meeting which gives a foundation to that with all the leaders are here. Our incoming Vice President Prashant Sabod, Ruchi Nanavati, Madam, she is a Diane in the field of neonatology, and all their help will definitely will make a big difference in the Indian Academy of Pediatrics policy and working tandem with the government and other organized stakeholders who has been in with the more important unless we engage a community. That is why IAP ke baad community ke saath during that time also where we have been newborn care which has been emphasized in that also. These are some of the measures which has been taken by Indian Academy of Pediatrics. Much more is going to come in coming days. With these few words, best wishes for the today's program. Thank you very much.
Thank you so much, sir. Thank you. Now I would invite Dr. Vasant, sir, to say a few words, sir. Please. Thank you.
Welcome, Shobna Madam is joined. Welcome, Shobna Madam. Shobna Gupta Madam, our Deputy Commissioner of Government of India.
Dr. Basaraj, Dr. Shobna Gupta is not well. HSC is online. Yeah. Shobna Madam, please.
So, in spite of the not being well, look at the Madam's commitment.
Yeah, thank you, Shobna Madam. If you are not well, just I had a talk, but in spite you traveled last night for 10 to 12 hours and then still that shows your entho for the newborn healthcare. Thank you. Please.
Yeah. Very good morning, everyone. Indian Academy of Pediatrics, Dr. Basavraj, Dr. Vasant, Dr. Japarik, and all the esteemed the members from the UNICEF, all the esteemed pediatricians from across the country. So it is really heartening to see that how Indian Academy of Pediatrics is actually, always collaborate and is always a innate part of whatever is the commitment of the government of India and definitely for all of us. So as we are here, talking about the National Newborn Week and the newborn health, and definitely about the objectives of India Newborn Action Plan, which we all aspire to achieve, and being, to achieve the single digit neonatal mortality by 2030. So definitely, as Dr. I was just listening to Dr. Basavraj, a lot of collective efforts are required by all of us. And as we can see, it's not only being why Indian Academy of Pediatrics actually becomes really important. That as you can see that it is still the healthcare in India is being governed by both the public and the private setup, and more than 50% of the facilities are still in the population is being served by the private setup. But when we talk about our country goals, they are collective. They have to be achieved by all the population, whether the child is being going into the public setup or a government or a private setup. It is a collective responsibility that every child should receive the care, every newborn should receive the care with equal equity at all the regions. So though our 6 states have already achieved the SDG of single digit, however, still 6 or 7 states are still even above the national target. And within the states, there is a lot of heterogeneity when it comes to the newborn mortality rate, and the stillbirth is again a long to go. So if we really want to achieve the equity across the country, and not only equity, the quality of the care that whoever newborn is receiving, actually as we talk in the India Newborn Action Plan also, that the survival, the thrival beyond, the care beyond survival. So that's a very important component, that we should not be giving the society a child. Basically, there should be intact survival, and it's our collective efforts that the disability should not be increased. Rather, we should focus on the early interventions. and the quality parameters, so that we raise and our demographic dividend is actually healthy in coming times. So with IAP having, so many pediatricians, 40,000 pediatricians, it becomes very important that our pediatricians who are working in the corners of the country, they align with the national or the global goals, with the national guidelines. And they are, even when the child, because it's actually as you say, the IEP ki baat community ke saath. So it's a collective same cohort where the child is going from hospital to the community to a private practitioner or a public. So we should all together be able to work towards that goal. So it's really important that whatever the Government of India's action plan, initiatives and guidelines are there, they reach to each and every pediatrician of the country, so that collectively we can all move forward. And the theme of this National Newborn Week actually we kept as the antimicrobial resistance, that we have to optimize the antimicrobial use so as to give the good choice of antibiotics and the rational use of antibiotics, which is very, very important in coming times, that we all should work towards this. Otherwise, in coming generations, actually, we won't be having drugs left for our children to treat when it is actually required. So that sensitization and awareness at every corner of the country. So we cannot talk about just one or two facilities or government facility. It has to be across One Health, across animals, plants, or the human beings or the children. We have to be aware and sensitized towards this. And I think with this initiative, we are working towards that very well. And I'm sure in coming times, with our collective efforts, we should be able to reach our country where we aspire to. Viksit Bharat 2047, it's all our vision of the Honorable PM. So we should be able to achieve this. On that note, thank you so much and all the very best to all of you for this workshop. Thank you so much.
Thank you, Subha madam. And it's an encouraging word, and I see the serve of you for collaboration with
IAP. It will definitely do. I promise you, along with when I'm having a team like Dr. Basavaraja, Dr. Atanu, Dr. Yogesh, and all my 80 EBs in year 2025 and 80 EBs in 22. It's a pool of there are about 200 our members who are the who will be key person along with the 46,000 members. I promise you that we will do the best. And now we again in this pool, we want to join 36,000 obstetricians, that's a Foxy group. So it will be a pool of 90,000 members. Who is going to help you? So sorry. Sorry. Foxy representative is sitting there. So first hand information. So 46 plus 45, it will be 91,000. So definitely, it's a major working force will be with you. So respected Dr. Basavaraja, our really dynamic last 1 year, you saw the first energetic year with a lot of academic, lot of social work, and we have started that IAP ki baat community ke saath. I don't think in last 62 years the work was done. It's a beyond imagining in year 2024. I really want to congratulate Dr. Basavaraja and his team, and thank you for including me and along with this. I was one of the team member. Our treasurer, कभी भी पैसे की इस साल कमी नहीं पड़ी है. He was the first treasurer outside as a national level. He's from West Bengal, Dr. Atanu Bhadra. Dr. Yogesh Parekh is absentia. Our respected Vice President from Northern, Dr. Satish Sharma. Yogesh, the नाम लिया और Dr. Yogesh bhai, please take a seat. Yogesh bhai, please take a seat. Yeah. Yeah. Welcome, Dr. Yogesh. Our secretary is there. तारीफ पहले ही होगी आपकी actually. So and my all EB and from I will not take naam to lead it, and from UNICEF, most respected Dr. Ramit. Then our Dr. Mangesh. इन लोगों को कभी भी फोन करो तो they always say yes boss, yes boss. So it's really an honor to stand before you today to inaugurate the National Newborn Week workshop being hosted jointly by IAP and UNICEF together, focusing on critical theme that optimizing use of antibiotic to prevent antimicrobial resistance in newborn. To achieve our SDG, that's a single digit newborn mortality. This is an opportunity to raise awareness about newborn care, to reinforce our collaborative commitment to ensuring that every newborn in India has the best possible start in life so that we will get a healthy India. The first few days and weeks of life are critical for survival and healthy development. Tragically, despite tremendous progress, India still faces a significant burden of newborn mortality, with thousands of infants losing their lives every day due to complications such as infection, preterm birth, and lack of proper care at birth. As we gather here, we are reminded of the immense responsibility we carry in caring for our most vulnerable patients, newborn. These tiny lives depend on our expertise and commitment to their health and well-being. However, the rising tide of antimicrobial resistance poses a significant threat to our efforts. It is imperative that we address this challenge head on. So, already Dr. Basavaraja told what IAP is doing. I think there is no need, but in short, I will tell. So, Indian Academy of Pediatrics, with its network of 46,000 members, what we are doing? We are raising awareness, educate families, community, and you have seen that IAP ki baat community ke saath. We are till now we have got 3,50,000 followers and getting the advantage of this our scientific material we are giving. Till now we have covered so many topics like Down syndrome, anemia, obesity, vaccination, cup, all these, and more are going to come. This year we are going ahead to this, and we are going to make a roundtable meet or like a that to be available for a community as well as doctor. And we are also trying to have a documentary, as a short film of 18 minutes, which will give the message how to prevent it, how to cure it, and how to recognize the signs. Like if you take the example of obesity, we are making film on obesity, which is going to tell common person that how to curb the obesity. Advocate for better policy. We want to work with government, UNICEF. So we are all already working for that to ensure that newborn care is a priority at both the national level and local level. NRP is a best example we are doing for that. Promoting research. IAP is always in forefront for research. I will tell you the one of the best project is going on in South, that is by Dr. Chandrakala. She is having the education of the health care worker for newborn care. And yesterday we had some of the 50% that study report came. The wherever they are working for that, the neonatal mortality reduced by 30%. That's a great achievement, I think so. And provide training and support. We are always in forefront to provide training for health worker, nursing cares, and National Shishu Suraksha mission was one of the best example where IAP had done a lot of work in newborn care to training health worker. So, in my opinion, what we should do first and foremost is implementing evidence-based guideline. That is the need of time. So we have to equip ourselves with the latest research and clinical guidelines to ensure that antibiotic are prescribed judiciously based on clear indication and targeted therapy. So we should follow that antibiotic stewardship or use antibiotic judiciously. Promoting stewardship program, enhancing education and training, which is going on, but there is a need to more and more education for healthcare professional and our healthcare worker. Collaboration and research. I already told what is going on, but again, we have to boost up ourselves for collaboration with the government, NGOs, including all NGOs like a Rotary, Lions, so many charitable organizations. We have to collaborate with them, and then again come to UNICEF, WHO, Kavi, and all this government. So we are having a too much scope. If we get a chance, very good chance, we can do a wonder. And my request for UNICEF people to get collaborate for more and more projects. We are ready for you. And engaging family, the most important part, that educating parent about an importance of appropriate antibiotic use and the risk of AMR can help create a supportive environment for our neonatal practices. Last but not the least, we have to go to government, and we need to revise the rates of the Ayushman Bharat. That is very important, because at least looking at the scenario of India, 50% patient goes to government sector and 50% patient goes to private sector. And definitely this rate of Ayushman Bharat is so terrible. It is very difficult to manage newborn. At least I am saying newborn and critical care in that rate. My request, everyone, we are working on this. Dr. Bidri from this Vijapur, and Dr. Manish Sharma, and we had a meeting how to go ahead, how to go to government. We are trying hard, but your all support is needed for that. My request to government people also to them. So coming to our vision is to create a future where every newborn in India is given the chance to thrive. We envision a society where no child dies due to preventable causes, where every newborn receives timely and appropriate care, and where families are empowered with the knowledge to support their children's health. As a pediatrician, we have the power to shape the future of our nation by safeguarding the health of our youngest citizen. Let us come together during this week to renew our commitment to newborn care, advocate for changes, and work toward a brighter, healthier future for all children. Together, we can make a significant stride toward optimizing antibiotic use and safeguarding the future of neonatal care. Before I end, I want to thank all the faculties who come somewhere from a long distance to share their knowledge. Thank you, and I will need this throughout year, your help. Thank you once again for your dedication and commitment to this vital cause. Let us work together to ensure that every newborn has the best possible start in life from the three top antimicrobial register. Thank you. Jai Hind, Jai IAP.
Thank you so much, sir. Now I would invite Dr. Yogesh Parikh, sir. Sorry, Yogesh Parikh, sir, just to say a few words, sir. Thank you.
So good morning, all respected seniors and dear friends. Here we have our beloved President Dr. G. Basavaraj sir and President Dr. Vasan Khalatkar sir. My dear friend Dr. Atunda and Dr. Pramit, and all the EB members and OB member, Dr. Satish Sharma sir, newly elected Vice President Dr. Prasanth Sabot, and Dr. Ravindra Sonwade sir, and the office bearer of the Mumbai IAP and the Navi Mumbai IAP. So thank you very much for attending this very important topic today, supported by the UNICEF. And always Pramit is behind us for all the newborn activity, environment activity, adolescent activity, and Dr. Sukanta Chatterjee sir is always for this noble cause. So thank you very much. And I think this is the AMR is a very important tool we have to address, because IAP doing so much work since more than decades for the AMR. I think Dr. Vijay Vale sir and Dr. Digar Sastry, Dr. Santosh Sons, and all ID chapters persons, office bearers have worked for this. And the Government of India has taken the notice and credit of this our IAP programs, because I once before 6 months I have attended the very important meeting in the with the WHO, with the UNICEF and the Government of India at the IMA, and the IMA people have recognized this. Dr. Jitu also conveyed the message that the best presentation we have done on behalf of the IAP. So that is the credit and of the IAP. So let us work together and have a some significant change as our President-elect Dr. Vasant Khalra wants to for the next coming years. So thank you very much.
Thank you so much, sir. Now I would invite Dr. Prabhat Srivastava sir just to have a few words on the status of newborn in India, the bottleneck and the recommendations. Thank you.
So respected Dr. Shobna ma'am, Dr. Basavraj, Dr. Yogesh Parekh sir, Dr. Vasant, and all respected IAP members. Now in morning session, we had a plenary session where we had discussed a lot about the interventions around the 6 pillars for reducing the neonatal mortality rate. I just want to reiterate what Dr. Shobna has said, that despite having a lot of progress in decline in neonatal mortality rate, there is still a lot of heterogeneity. I mean, we have on one hand a state like Kerala, where we have neonatal mortality rate as low as 3. And we have a state like Madhya Pradesh, where we have an NMR of 30 per thousand. So it was easier initially. There are certain steps which we had taken. And with those efforts, a lot of trainings and other things, we have reached to a point now where we are aspiring towards going for a single digit. And I'm sure that we will be able to reach by 2030 itself. Now, where the problem is lying is, I mean, despite having the single digit NMR, still the states which have the high neonatal mortality rate, they also have a huge population. So they have a huge cohort. The states like UP, Bihar, Madhya Pradesh, they have, if we talk in terms of number, this number is still very huge. So and it is an opportunity where Foxy and IAP and UNICEF, we are all coming together, and we are planning for next 2-3 years to find certain activities, to form an action plan where Foxy, IAP, we all and UNICEF, we all work together to identify the bottlenecks, where exactly we are lagging behind. What exact intervention we can do to accelerate the progress to the single digit NMR. In the morning, we had started with the preconception part. We had also discussed the challenges of use of antenatal corticosteroids, and also discussed some of the interventions that are already in place. We need to substantiate the recent advances, like from KMC to IKMC, or the use of CPAP, or ensuring the quality of care in the NICUs and SNCUs. And we also talked about the partnership between the public-private partnership. Now, with so much of funds available with NHM, what we are seeing that there is enough operational funds for maximizing the capacity of government facilities. But still, if you go to the private, a lot of work needed to be done. We have seen newborns, the babies who are coming from the private institute. They have been mishandled, and they are reaching to the government facilities. Though the number of, I mean, it depends. It varies from district to district. It varies from place to place. But many a times we have seen there is still the golden hour, which is very, very important for managing the newborn, has been missed in most of the cases. So how can we work together? How can we streamline our referral system? That is the entire objective of having this workshop uh, in the National Newborn Week, which always comes up with a theme. This year we have a theme of optimizing use of antibiotics, and as a pediatricians, we need to look at ourselves whether the guidelines that is coming from national level or from the IAP, they have been implemented not only in the government sector but also in the private sector. What are the first line of antibiotics they have been used? What are the antibiotic policy? Whether each district or each unit has its own antibiogram done? Whether the local on the basis of that local antibiogram, that antibiotics have been used or not. So we need to not only sit here, but also go to our individual state offices and to see where we can work together to reach to the maximum utilizing this National Newborn Week opportunity to optimize the use of antimicrobials. So that's all from my side. All wishes. Thank you.
Thank you so much. Now we will just have our lamp lighting. So I would invite all our this yes, Aditya and Sati sir, Shukanta sir, Ruchi ma'am, please. Yeah, yeah, Dr. Mangesh, please for the lamp lighting. Thank you.
Yes, I so it's recommended. We're not already. वीडियो भी जाएगा वीडियो भी डालेगा सेंटर में इसको लिखने बहुत बढ़िया आज भाई जल्दी काम ही करता रहेगा पोर्टल में भी नहीं आएगा वैसे ही उसका अभी तक ऐसा है थोड़ा
Thank you. Now we will move on to our next session. That will be keynote address by Dr. Mangesh Gadhari, and he is an health specialist attached to Maharashtra branch. Dr. Mangesh.
Very good afternoon and good morning as well, since morning we are sitting here. Hello. Sorry. First of all, I would like to congratulate IAP and Foxy for this event. And also I would like to apologize because unfortunately Mr. Sanjay cannot join because of his health. He really wanted to join this event and he always admires the events organized by IAP. So I'm just conveying the message that he has shared with us for this particular event. To start, before starting my message from Mr. Sanjay is, I would like to give a sincere gratitude and thanks to Dr. Shobna from Ministry of Health Family Welfare, Dr. Basavaraja, our current President IAP, Dr. Upendra, past President IAP, Dr. Khalatkar, now the next president IAP, Dr. Yogesh Parikh sir, and everybody. The kind of partnership that UNICEF had for several years with IAP, and now we are looking after having a partnership with Foxy as well. Though with Foxy also UNICEF had partnership in past. So these kind of partnerships are very essential, very important, and particularly for the agenda of the vulnerable groups like newborns, like mothers, like adolescents, and everything. And as Dr. Shobna has mentioned in her talk, that India is set to achieve the sustainable development goal of achieving 12 per thousand newborn mortality rate. But so that definitely will be achieved for sure. But what we are aspiring for is the newborn mortality rate as per the India Newborn Action Plan of a single digit, and not only NMR but also the stillbirth rate of a single digit. So that is there, and in this direction, Minister has already taken a lot of steps in terms of revising the faith-based, facility-based newborn care guidelines, in terms of revising or coming up with the version 2 of home-based newborn care, home-based young child care guidelines. So these kind of things are definitely going to support. Now, this National Newborn Week, which has been celebrated by India since 2000, so every year between 15th of November to 21st of November, this Newborn Week is celebrated, and every year some new theme is being taken forward to do the work for the rest of the year. This antimicrobial resistance is something which is not new. I have been working in the remotest of the district in Maharashtra since 2011, and I've seen and we have heard about the microbial resistance for the tuberculosis and all those things. And so far we have been talking about this antimicrobial resistance for adults. Now the time has come that we also should focus on the antimicrobial resistance for newborns. For India, for many other states in India, though the child mortality has substantially reduced in last 2 decades, the pain point for reducing the child mortality, for that matter, is the newborn mortality. So the among the deaths in children less than 5 years, the maximum deaths happens in less than 1 year. Among the deaths in infants less than 1 year, maximum deaths happens in the newborn period, and even in that, the deaths happen in the first 7 days, that the early newborn mortality. And after making substantial progress into this reduction of newborn mortality, infant mortality, child mortality, the last mile will always be difficult. And that is where we have to address these issues like antimicrobial resistance and an optimal utilization of the antibiotics. Because if that is done, then definitely we can reduce. And then, as Madam has mentioned, that there are very few antibiotics which are available and we use for the newborns particularly. And doctors are also very careful, or some new doctors are not very confident to use these antibiotics, the higher antibiotics. So in such case, if the antibiotic resistance develops, then it will become all the more difficult. And that is why this particular theme, which has been chosen by ministry for this newborn week celebration, National Newborn Week celebration, of optimizing the antimicrobial use and antimicrobial resistance addressing, is very apt. And so the message is that this addressing this antimicrobial resistance is all the more pertinent to address the 3 things which Dr. Shobna has mentioned: quality, equity, and dignity. To these 3 things, I would like to add one particular term, that is safety of these newborns in these SNCUs, these in NICUs, or all these care centers where the newborns are addressed. So that is the message, and I would like to reiterate the fact that to Dr. Khalatkar, to Dr. Basavaraja, Dr. Yogesh, and everybody, that UNICEF has always been there to partner with the professional associations like IAP, Foxy, because you have that strength, the membership, the kind of numbers that IAP can reach with 46,000 IAP members, 45,000 Foxy members. This is a tremendous support, and we would like to continue this partnership in future in 2024, 2025, and even further. Thank you so much.
Thank you so much, Dr. Mangesh. Now I would call upon Dr. Atanu Badru, sir, just to say a few vote of thanks, sir. Thank you.
So I think already our president and president-elect and secretary has given almost the vote of thanks to everyone. So we won't be repeating it. Just to say, UNICEF for coming up with the program. We did it in a very short time. And uh, I think every one of us knows about UNICEF. They work in almost the toughest situation, started with pre-war and post-war situation where children were at risk. But now the spectrum has widened, and today we are having a joint program on neonatal survival and intact survival. So I thank Vivek in absence here, because he was in our meeting. He was took up the initiative, and Dr. Promit took up from that side. And from our end, from end of IAP, Dr. Jitendra Gawane, please, a selfless worker. Jitu, कहाँ है भाई? काम में लगा हुआ है. And Dr. Tanushree Mukherjee, so working tirelessly for the last 2 weeks for having this program done. And we thank all of you for putting the flag of IAP high. And Dr. Pramit, yes, IAP is clearly poised to work. This had been a landmark year where we had plenty of programs on different advocacy issues with UNICEF. And in fact, history was waiting to happen, because the moment Dr. Vasan became as a president-elect, and our relationship with Foxy improved, and we had joint programs everywhere. Thank you, Dr. Pragati ma'am, for taking the initiative. And I hope that it will continue, and we'll have, in fact, Shukanto sir have already come up with a joint professional organization. Yeah. So all these things needs plenty of background work, and we need advocacies from all of the IAPians. So more than 50,000 members with a network of almost 350 branches, and with an experience of training already. We had trained almost 10,000 of our members in early childhood development. So we look forward to UNICEF to getting up this type of program, where IAP is very specialized in training across the country, reaching the unreached and reaching the cities or towns, tier 2, tier 3, and even rural areas where our branches are very active. People like Dr. Joshi and Archana ma'am already working in such areas. So, and again, thank you for all of us. You are handpicked by our president and president-elect, who we thought that could take this workshop, the concept of this workshop, uh, to your areas, back to your areas, and probably we want to continue this initiative about newborn week. I also thank all of you who traveled all the way, and our office staff who made it possible for this workshop, the background work. Thank you, all of you, and I think we can delay our lunch a bit so that we can have the panel. Thank you.
Thank you so much. So with that, we will move on to our next panel discussion, and that was the main motto of this year's next newborn week as well. So the panel discussion, our topic is reducing infection in neonate and towards the antibiotic stewardship. For that, I would like to invite Ruchi Nanavati ma'am. Ma'am needs no introduction. Ma'am is teacher of our teachers, and ma'am is a very renowned neonatologist, professor, and head of KEM Hospital. Welcome you, ma'am. Thank you. And our panelist today is Dr. Sahana Devdas. Ma'am is professor, Bangalore Medical College. Ma'am. Then Dr. Swapnil Visikar. He is a neonatologist attached with Krishna Institute of Medical Science, Cuddles in Nagpur. Then Dr. Om Prakash Jamadar. He is a neonatologist with Apollo Hospital, Navi Mumbai. Welcome, Dr. Om. And Dr. Hemant Sharma. He is a neonatologist in Amrita Hospital, Faridabad. So, a complete neonatologist panel. So, welcome you all, and I will hand over the mic to ma'am. Please, ma'am.
Good afternoon, senior pediatricians, my friends and colleagues. At the outset, I would like to thank and pay my sincere gratitude to our beloved organization, mother organization, Indian Academy of Pediatrics, for celebrating the Newborn Week in a grand way. And as the government has said, that this time's theme is optimizing antimicrobial use to prevent antimicrobial resistance. And when we speak of newborns, the newborn challenge faced by India is voluminous and different from any other country in the world. As we know, that 25 million babies are born every year. And 25 million is more than the population of certain countries in Europe. This many babies are born. 18% of them are low birth weight and 13% are preterm babies. And these low birth weight babies, preterm babies, they actually form a group, what is called as small vulnerable newborns. This term was introduced in Lancet in May 2023, that these are small vulnerable newborns. And this is important because they contribute to more than 55.3% of neonatal deaths. So when we are managing newborns, the first question should be, am I handling a small vulnerable newborn? And when we look at the causes of their death, the sepsis contributes to more than about 50%, statistically 33%, but a lot of low birth weight babies die because of infection. So it comes to almost about 52%. And that's why this is the topic of the day. And we have expert panelists from all over the country to discuss about how can we prevent antimicrobial resistance and the antibiotic stewardship. So with this, the next slide, next. So we are here to celebrate Newborn Week, the next. And our panel discussion is on reducing infection in neonates and towards antibiotic stewardship. Next. Now, when we are talking about this, I'm not spending a lot of time in introducing the people, our panelists, but we have Dr. Swapnil Biskar, who is a neonatologist from King's Garden, Nagpur. I'm not going into the details because we want to discuss about the topic. Dr. Om Prakash Jamadar, neonatologist from Apollo Hospital, Navi Mumbai. So he's actually a host here. Dr. Sahana Devdas, who is a professor and HOD of pediatrics from BMC RR Hospital from Bangalore, and Dr. Hemant Sharma, neonatologist from Amrita Hospital, Faridabad. So we have actually the representation from each and every zone of the country. And this, now the next slide. Now, this is all of us who have worked in newborns. We know that there are challenges, whether you are working in a private setup or you're working in a public setting. When you're talking about newborn care, there are a lot of challenges. Sometimes we are successful in managing them. Sometimes there are a lot of obstacles, but efforts continue. And that's what we have done for last so many years. The next. And this is a very important slide because this slide, the next, it is written in 1994 that are we losing a war against pathogens? So 30 years down the line in 2024, we are discussing the same thing, that what is happening to, antibiotics and antimicrobial resistance. The next. So with this in mind, we are going to talk about antimicrobial resistance. So my first question is to Dr. Swapnil, that when we talk about infection, why are we so much worried? That why are you worried when you talk about infection and why do you want to reduce it?
Thank you, ma'am, for this question. I would like to start with this thing just by briefing that whenever we are in NICU and in teaching institute, ma'am was teacher to me. And whenever a symptom is asked, why the symptom is there in the baby, for example, stridor, so it will always start with that sepsis. The thing is that sepsis. So whenever the thing is, ma'am got so much fed up that ठीक है sepsis तो है, आगे तो बताओ इसके अलावा और क्या हो सकता है. So the thought process started developing after that. Yes, sepsis could be one of the reason, but you should be able to pinpoint four other reasons apart from sepsis. So as things are growing, we are also learning. We are learning different symptoms of this sepsis per se. So in short, we can say that sepsis manifests in terms of dysregulation of the what we call as a autoimmune system, as well as when the baby is not able to handle that hemodynamic compromise. So it can manifest in terms of a metabolic abnormality, in terms of anything from hypoglycemia to hyperglycemia, from hyponatremia to hypernatremia, from hypocalcemia, anything. Similarly, the babies can manifest with hemodynamic compromise. It could be, yes, we were learning that it can cause shock, But yes, it can also lead to increased blood pressure also. Thrombotic complication has manifestation on itself. It could be a short term, it could be lead to a long term complications, gut manifestation. So you can enumerate anything, any organs can be affected with a sepsis, which can lead to a complete recovery or a recovery with some kind of a scar or a recovery with a permanent disability. So in long term, babies can have correctable or permanent disabilities. They can have growth faltering. They can have hearing defects, visual defects, intellectual abnormalities, bone deformities, hydrocephalus, and numerous. So this is the view as a clinician we can say. But having a bird view, when you move to the society and you to move to the unit, so an ICU increasing the burden of sepsis leads to increased expenditures of whatever things are going along, increase number of a stay the baby you're going to spend in the ICUs. For parents, obviously that is increase their burden to financial burden, increasing stress, and in the community you are absolutely adding number of preterm babies or a term babies or getting sepsis and having morbidities, disability into the societies. At the same time, which I have not mentioned here is dysbiosis, which is topic of the town today nowadays. That once a baby gets sepsis and the baby is harboring those kind of organisms, which causes dysbiosis, leading to number of adult diseases, which is called as a POD.
So I think, you have brought up very well that when the babies get infection, is you're not looking at only the short-term outcome, but the implications are long-term. The babies who have ureaplasma, urealyticum infection, they can cause CP in the child. So it's not only the short-term problems, but you can have long-term problems which can last for lifelong. And that's why reducing infection in neonates should be our priority. So the next slide. So my next question is to Dr. Om Prakash, that are neonates more vulnerable? And if you feel yes, give us the reasons.
Thank you, IAP team members and UNICEF for giving this opportunity. So as Madam rightly said, the term vulnerable has been recently put in the Lancet also, because this is a special population. It's not just the preterm babies, but I will say even term babies are also at risk of infections if essential steps are not taken care at the time of birth, as well as in utero exposure of the maternal antibiotics and all that things also increase the risk of NEC and late onset sepsis in the babies. So looking at the immunity development in the babies, the passive immunity that the baby gets from the mother is only IgG antibodies. And that also, if you see, over a period of time, it weans off. And it's not that for all bacteria that baby is going to get exposed in the immediate time frame, the immunity is there. That is one part. And if you look at the active immunity development, the self antibodies, particularly IgM and all the other components, they are not yet mature for term baby, as well as they are very immature in a preterm baby. The second antibody that the baby gets passively is the IgA, and that is only possible if baby is getting mother's milk, and that does help protection from the respiratory and the GI component, but not other bloodstream infection. So we can see the immunity is mature, whether it is active immunity or passive immunity. And on the top, if the baby is born preterm, what happens? Baby is taken away from the mother, so there is no immediate skin to skin contact that helps for preventing certain infections for the babies. The baby is taken to the NICU for certain invasive procedures. It may be as simple as a cannula insertion or as invasive as a ventilation and long line insertion. So the natural barrier of the skin is broken. There is no early initiation of the feeds, and many a times if mother and baby are away, there is formula which is started as a first feeding maneuver for the babies. So all these factors increases the risk of infection, and that is what this term of being vulnerable as coming in the picture.
So if we look at this newborn, what happens to this child? That why is the baby more vulnerable? Next is because these babies have immature immunity, as he has already said. We use broad spectrum antibiotics sometimes which are not indicated at that time, and they have life sustaining invasive interventions like ventilation, central lines, and so many things in the newborn babies. And this prolonged hospital stay, which causes colonization with potentially pathogenic organisms, makes this baby at a risk of developing infection, even something like fungal infection, infections with even low vulnerable organisms, they can get infection, and these babies can have problem immediately and lifelong. So we need to address this. The next question goes to Dr. Sahana, that what should be the different strategies in prevention and reduction of infection in neonates?
Thank you, ma'am. Thanks for that IAP and UNICEF for giving us this opportunity. So preventing and reducing infections in the newborns requires a multifaceted approach that targets one is maternal, perinatal, and the neonatal factors. So what are the key strategies we have? So one is prenatal interventions. A lot of things have happened from the morning, the discussions about the maternal infection screening and treatment of the most common conditions like your urinary tract infections. There could be asymptomatic bacteriuria, we all know in the mothers. And maternal vaccinations during pregnancy. Of course, with the advent of TT has gone up and TD is the thing. And even in the private sector, we are emphasizing on TDAP is what we are emphasizing for these mothers. And also the co-vaccine. After COVID, we all know that COVID vaccines are also there for the mothers. And in term of, we also have, please. Yeah, and maternal vaccination and management of the preterm birth risk. And most of the mothers who are delivering we have deliveries about 1,400 per month. It's a biggest unit and 40 to 50 deliveries per day. And most of them are now delivering the teenage pregnancies or the maximum, including our POXO cases, etc., etc. So we have to curtail about the prevention of the preterm deliveries itself and nutrition and hygiene education to these vulnerable mothers, young mothers, what we have. And we all know that anemia, Mukbarat, everything is there. Still, our anemia in the pregnancy is very, very high despite doing that. And intrapartum interventions, yes, hygienic birth practices are utmost important and avoiding unnecessary invasive procedures. Skin to skin contact from morning, everybody are emphasizing it is everybody know about skin to skin. But in our hospital, I keep an audit when I'm bumping into the labor rooms while going for the NICU rounds. And skin to skin, yes, babies are put for 5 minutes. That is not, skin to skin contact is not 5 minutes. It is for 1 solid hour. And I keep asking the mothers, I do an audit and go back and bang on the obstetricians and the labor room nurses. Sorry to say this, ma'am. Yeah, skin to skin should be given for 1 solid hour till that baby crawls. And even the weighing the baby, your immunization should be done after 1 hour. None of majority of the people, they do not know about the 9 stages, what happens on the mother's abdomen. And then sterile equipment and IKMC, many have thrown the light. And minimizing cross-contamination and cohorting these infected babies, you should have a special place for a HBS AG mom or a VDR positive, and even the HIV mothers, they have to be cohorted. And umbilical cord care is very, very important. And hand hygiene, though appears simple, is the best way to save the lives and preventing infections everywhere. As per the city's healthcare associated infection comes down with the hand hygiene. Compliance, you can do an audit, education, and readily available. Education, every one of us know that hand hygiene is important, but how much to take the hand sanitizer and are we doing all the 6 steps in that 20 to 30 seconds is questionable. And environmental and community level interventions, yes, we all should have a facility-based newborn care and education of the caregivers also. Some of the myths, they come from a rural background. So we don't know, there are certain harmful traditional practices among the parents, mother and babies are kept out for so many days. And then community hygiene is also very important. Of course, breastfeeding and nutrition is the most important part in preventing infections. We all know about, as per the NFHS data, only 41% of the babies are started early initiation of the breastfeeding and exclusive breastfeeding only 60%. Even that is doubtful about that. And we all know about the probiotic. These are all some of the interventions at the NICU level we can do. So central line, this comes in the neonatal intensive care unit regarding your care bundles, like IV care bundles are said, and CLAPSI bundle, WAP bundle, etc. Judicious antibiotic use. Avoid unnecessary antibiotic in low-risk infants. Just because baby has come into the SNCU, maybe for a jaundice or your exchange transfusion or meconium aspiration or your birth asphyxia, antibiotic is not the answer. And promote antimicrobial stewardship programs and with the empiric antibiotic and prophylactic measures like your extreme preterm babies where your rate of fungal sepsis is more than 10%, you can add fluconazole for these babies. And yeah, and skin antisepsis. Of course, coconut oil is the age-old thing which helps in reducing the sepsis. We have done a study, it has to be published. And environmental cleaning and NICU design. It is not that doctors know about this or neonatologists know about that, including the group D emphasizing on the other people, this is very, very important. You can have a camera, but my superintendent said, already you're troubling, we'll never give you a CCTV. Yeah, CC camera, okay? Yeah, thank you so much.
Thank you, Dr. Sana, for giving a comprehensive, view to that question, right, starting from prenatal interventions right up to follow-up, what these babies actually deserve. So when we are working in NICU, in spite of so many years of working, sometimes you do have, questions in your mind that, should I start antibiotics in this baby? Then someone will start, change the antibiotics to this thing only because you are a senior, you are taking around. Sometimes it happens that you change the antibiotics. So I would like to have the evidence-based guidelines from Dr. Hemant, that what are the indications for initiation and second for the upgradation of antibiotic therapy.
Thank you, ma'am. Ma'am, there should be solid reasons always to start antibiotics. There's always a war going on between microbiomes and human and or antibiotics. And now it's there that we're not going to win the war. So we have to have a ceasefire so that the damage is not further. And development of antibiotics is much, much delayed than the resistance coming up. So, and especially developing countries like India, we are far way behind. We are using higher antibiotic, higher spectrum of antibiotics, and costly antibiotic. So here we need to have the answer that why should at first place we start antibiotics. And there are certain risk factors that have, like IAP standard treatment guidelines for neonatal sepsis, they published them, and NFF published them. We have to find solid reasons to start them. There are certain risk factors, and there are like perinatal risk factor, like prolonged rupture of membrane or spontaneous preterm labor, prolonged labor. So they are risk factor, but or not extreme risk factor. A single factor in isolation, and the baby is not symptomatic, especially in a term baby or baby who's like more than 34 weeks, it's not an indication for starting antibiotic. An extreme risk factor or a combination of multiple risk factor with a symptomatic baby or a preterm baby definitely warranted initiation of antibiotic. Plus, they should be microbiologically confirmed, or at least we should have a standard, the timeline that this baby will start and this time will stop the antibiotic. Here, if you go through this IAP standard treatment guideline, they say to initiate that the orange boxes down, they say that we have to initiate antibiotic here. So one is extreme risk factor present, or a sepsis screen that is present positive in symptomatic baby. Asymptomatic baby with a marginal rise of CRP does not warrant an antibiotic also. So I'll say in brief, a symptomatic child or a vulnerable child that is like less than 34 week with extreme risk factor or at least some multiple risk factor present. Upgradation of antibiotic, first of all, we should know where not to start or upgrade an antibiotic. So in a well preterm child, mother having hypertension, delivered for a PIH or a normal Doppler, that doesn't warrant an antibiotic. Putting a cannula doesn't warrant an antibiotic. An asphyxiated baby, unless there's evidence of leaking or a maternal, chorioamnitis, that doesn't warrant an antibiotic. Meconium aspiration, frequently we give antibiotic in a meconium aspiration child. When there's a clear history of meconium aspiration, that doesn't warrant an antibiotic. And see, in meconium aspiration, CRP usually rise. So every rise in CRP doesn't warrant an antibiotic. So, and best way, if you are confused, if you are in a doubt that this could be sepsis, at least obtain a culture first, start an antibiotic, and then discontinue it early. So, escalation of antibiotic, first of all, we should have a unit protocol. There should be like level like the basic antibiotic, level 1 antibiotic, then upgrade to a second line antibiotic, and then the reserve antibiotic. And there should be a microbiological confirmation, at least for reserve antibiotics. There should be the clinical state of the baby. And for stopping antibiotic in a culture proven or a proven sepsis, then this inflammatory markers should be taken into consideration to stop antibiotics. And this is like we have to go with the microbiology, symptomatology, and other factors to initiate and stop antibiotics.
Thank you, Hemant. So I think continuation, discontinuation of antibiotics? How do you escalate and what do you do in case if there are outbreaks or you have resistant organisms? So I think that is very, very important. So whether you are a houseman in the department or you're a professor of the department, you are starting the same antibiotics. It's not, as a senior, you take round, you give second line or third line antibiotics. That should not happen. So I think it is brought out very well. With this, we go to the next question, and that is the topic of, the newborn week, that we come across antimicrobial resistance. So Swapnil, I'd like you to tell us that how does the resistance happen? We keep on talking resistance, but what does actually happen? So just please explain.
So, in case of a baby or a patient is harboring pathogenic organisms, and we start with antibiotics, generally it generally kills those organisms which are sensitive to those antibiotics, and ultimately the body is landed up with a number of organisms which is in very very minute number, which are resistant to those antibiotics. Now, slowly the thing is, if a patient is under continuous coverage of antibiotics, those resistant organisms which are small in number, they started growing more in numbers, and this kind of organism ultimately then produces infection which are called as a resistant the organisms resistant to the antibiotics. This is the usual way in which just easy to learn, but how do these microbes they develop resistance? There are only 3-4 theories in which they are able to express this resistance to the antibiotics. One is they are not allowing that antibiotics to to come inside the cell membrane of those organisms. Now, there are some of the way. Second way is that they efflux out once the antibiotic goes inside the cell membrane. Third is they have some kind of a enzyme which they modify in which those antibiotics get demolished or that get digested. The fourth way is that they don't have any kind of what you call as effect on because those microbes. This is the way in which mechanism is developed. Now, how this resistant organism they spread from one microbe to other. This is called as a vertical transmission. It's not like a similar to the vertical transmission of infection from the mother. It's a vertical transmission of the resistant gene, either through transduction or conjugation or transformation, or it may be we are also aware that slowly we are getting early onset sepsis which are resistant to the antibiotics. The reason for this thing is that because of the culture in which we are growing now, we are eating those kind of products which are highly processed, which are in which for example, the cow, in kind of whey proteins which have harboring the resistant organisms. This is the way in which resistant microbes they are developing inside the human body. Now, there is a one interesting thing in which is called as a de novo selection. It has been observed by a few of the doctors that if there is a unit in which they are not giving antibiotic to the patients, those unit will be having number of a sepsis with a sensitive organism is very high, and in the unit in which antibiotic usage is very high, number of resistant organism is increases. If you called as a crossover study, if you change the unit, the number of flora, that is called as antibiotic pressure, if it get removes, the number of organisms which are sensitive to the antibiotics that starts increasing. So judicious, ultimately what we are discussing is that if you use the antibiotic very judiciously, then you are able to save the babies very easily. Now, what are the practices which are likely increases the number of resistant organism? Specifically, we will talk very practically in culture negative sepsis. If it is unplanned, this is our first line, second line, third line, but there are 3-4 consultants which are working in the unit. Now, किसी का first line cefotaxime, किसी का first line piperacillin, किसी का first line gentamicin. So, if this kind of things are going on the unit, the number of resistant organisms which will increase. Now, use of a different broad spectrum antibiotics for substitute, what I have generally explained. Unplanned grading. चलो आज apnea लग रहा है. Let's increase from Piptas to meropenem. Now, another thing, meropenem 20 mg से क्यों देना है? Let's give it to 40 mg. We are able to save the baby earlier. The thought is simple. We all want to save the babies, but the thing is underlying what we are doing, how this is going to curtail, how this is going to perpetuate, we are not completely aware of. Now, prolonged duration of antibiotics. किसी को 7 दिन दे दे, किसी को 10 दिन दे दे, किसी को 14 days दे दिया, infection तो है. So TLC count is little bit lower. It is falling. It is increasing 21,000. It is going to 4,000. The change of antibiotic plan is that. So this kind of thing should not be there in cultured negative sepsis. Next slide. For culture positive sepsis, this is culture positive sepsis. The thing is that if culture positivity is there, use of a single antibiotic is what is required. And another thing, if a organism is sensitive to narrow spectrum antibiotic, we should have enough what you call it himmat to reduce it to that narrow spectrum antibiotics. Now, routine use of antifungal for associated that antibiotic associated thrombocytopenia, it's very much rampant. किसी को भी platelet कम दिखे हैं, you start adding amphotericin or fluconazole, but this should not be the scenarios. Now, limiting the duration of the antibiotic. Once you get a rapid recovery after starting antibiotics, you have to think that मैं इसका antibiotic how early I can stop. Whether I can continue for 10 days. Yes, obviously in corporate things, in private thing, the thing is that you want to increase to 10, not to 10 days, you want to increase to 14 days. But are we really justified? The thing is that you should keep in mind antibiotic pressure always in back of your mind. If you are using more antibiotic, अगले वाले आने वाले 3-4 months में you are going to get organisms which are resistant to what you are doing. Another thing, this is for small cities. After patients get recovered, अभी तो antibiotic का duration मतलब it's now yet to get completed. This sometimes the practice is that to shift from IV to oral antibiotics. So it's easy for the patients, for the parents also, but this should not be done because there are enough studies in which it has been found if you shift it, is number of resistant organism increases. So this is how in which the resistant organism flourish in your NICU. If you take few steps, critical steps, one step at a time, you are able to reduce the number of resistant organisms.
Thank you, Swapnil. You really brought out very nice and important practical points, and also concept of de-escalation of antibiotics which are given. So when we are talking all of this, is it only theory or antibiotic resistance we are seeing in India in the community also?
So this is very important. And in fact, this is the theme of this year's New 1 Week celebration, antimicrobial resistance. So we see early onset sepsis and late onset sepsis. In Western world, the organisms are different in terms of early onset and late onset. But in our scenario, there are same organisms, whether it is early onset sepsis or late onset sepsis. That is first thing. Now, if you see at this slide, this tells you how much significant is the antimicrobial resistance from 91 to 21. And now we can see down the line in 10 years time, I doubt whether this dish will be completely, just filled with the microorganisms, and then there is no any response to the antibiotic. So what we cater is, one is early onset sepsis, late onset sepsis. Second, we have got a grades of antibiotics in terms of our first line antibiotics, second line antibiotics, third line antibiotics. And then we look at the population of babies that we cater, whether they are inborn or outborn, because the flora is different. Now, looking at the first line, second line antibiotics, the antibiotics we used to give as a first line, they are no more first line. The third line have become the first line antibiotic, and that is the reason for development of the resistance. So there are different evidence from Indian scenario also. This is a study which was done by the Danish group where they looked they looked at the outborn babies. So here, if you see the outborn babies organisms, the 1/3 of these babies were referred from the home, and 2/3 were referred from the nursing homes or maybe surrounding NICUs. So even this 1/3 babies also have got a significant growth in terms of gram-negative organisms. If you take E. coli, Klebsiella, Pseudomonas, and all these organisms, the antibiotic what we use as a first line, second line, most of them are getting resistance. So if you see the intensity of resistance, if you look at this Klebsiella pneumonia and Acinetobacter, there was a high degree of multi-organ resistance, multi-drug resistance. So what is this multi-drug resistance? The antibiotic that we use, third generation cephalosporins, aminoglycosides. Then we use fluoroquinolones. Then we use as a carbapenem group, or we sometimes use piperacin cefodex, piperacin combination. So of these 5 antibiotics, if there is a resistance to the 3 antibiotic, then they used to label as a multi-drug resistance organism. So if you see the Klebsiella pneumonia, it has almost like a 38% resistant to the carbapenem group. And if you, previous slide, please, previous slide. Yeah. So if you look at the Klebsiella pneumonia, they showed a high degree of multi-drug resistance in terms of 78% resistance. So the number is quite high, And if you look at the Acinetobacter, there is a 91% multi-drug resistance bacteria. So out of these 5, the 3 drugs are resistant to this organism. And if you look at the carbapenem resistance, it is 84 and 91% resistance. So this is all about the outborn babies. Now looking further, the Danish study that we have opened eyes in 2016, that we are catering significant number of inborn babies also having similar sort of resistance. So the subsequent studies, next slide please. So here also if you see, so almost Acinetobacter 82% resistant, Klebsiella showing 54%, and E. coli showing 38% resistant. And this was a study in 2016 which was published. So we are way ahead. So I am very sure that the incidence has gone up significantly. You may say that this is from the North India. So we may say like Delhi bahut dur hai, aisa nahi hai. The nearest place for is Pune, So the KM Pune group, they have published their data. So they also showed 90% resistance to third generation cephalosporins, 60% resistance to aminoglycoside, and 30% resistance to even colistin also. So you can understand the severity of the problem, and we are the contributing factor for the problem. We should make a policy that the primary referral center, they should not start meropenem as their first antibiotic. They should not start directly piperazine tazobactam as the first antibiotic. And what is the consequence of all this? We are promoting the fungal sepsis. If you see the first study, there is a significant contribution of fungal sepsis because of this repeated exposure of the antibiotics. And whatever the procedure we are doing, our handling is also not good enough. So that is the reason the fungal sepsis is also going up. So we need to make sure that we need to be very sensitive when we start antibiotic. We should have a policy to stop antibiotic when we start antibiotic.
Oh God, so the situation is not in a very good this thing. And in fact, the Danish study is actually opens your eyes that what are we dealing with, what organisms, what antibiotic resistance. And that's why the NICU is not judged by how many hi-fi antibiotics you are using. If you happen to use hi-fi antibiotics in most of your patients, that means your infection control policies are poor and they are not adhered to. So, and we are not here for companies. We are basically in facility for our babies. So the next slide. So with this, the major question is that when we talk about antibiotics, what is antibiotic stewardship? What should we do? And I'd like Sahana to answer that.
Antibiotic stewardship, that is the need of the hour as per the current theme also. So it is a set of coordinated strategies which has to be optimized for the use of antibiotics, improving their outcomes and minimizing the resistant development as per the CDC. So there are three core components, that is empirical, antibiotic timeouts, and education and audits are very, very important. Just saying that I'm using the antimicrobial stewardship, lot of effort has to be taken by individuals. It is a collective. Together, everyone can achieve more. The team, the leader should be there along with them, everybody. And about the impact. So empirical, like starting off with a broad spectrum antibiotic, depending on the data, and then adjusting according to the culture positivity. And antibiotic timeouts, suppose you have started, review ongoing therapies, and after 48 to 72 hours, you should be, as ma'am said, stopping or de-escalating or stopping if culture negativity. And education and audit, every time you have to do in your own units about your antimicrobial stewardship. That is how many antibiotic days, how many babies are on antibiotics, because the SNCU software does not take antibiotics, yes or no. That has to be upgraded as per the things, and how many antibiotics that has to be done. The number of sepsis is shown as 6, but the antibiotics usage is more than 60 or 80. So there is a lot of discrepancy among them. Then impact on the neonatal care, so which prevents the emergence of resistant organisms. The first goal is to work with the healthcare practitioners to help each patient receive the most appropriate antimicrobial agent with the correct dose. The 4 things, the right drug, right dose, de-escalation, and the right duration have to be followed by all of us. Then the second goal is to prevent antimicrobial overuse, misuse, and abuse. So in both the hospital and outpatient settings, physicians and use of antibiotics wherever unnecessary. Now the flu season is up and all the babies with the flu, they come with a HFNC, they go for ventilation. The influenza and your Boca virus and RSV is rampant in our part of the things, but all are already on the antibiotics and referred with the highest antibiotics. Cetray, Vanco, like one combo, buy one, get one, that's horrific. Then the third is to minimize the development. Next, please. So this is in nutshell, there should be a coordinated actions designed to improve and measure the appropriate use of antimicrobials, optimal antimicrobial drug regime, and the optimal duration. So a lot of, the efforts have to be done for this. Yeah, thank you.
So, yeah, thank you, Sana, for the comprehensive answer. And I would like you to refer to this booklet published by WHO. We'll give you all the ideas about whatever we have discussed so far as the antibiotic stewardship is concerned. With this, we go to the next question. And the next question is to Dr. Heyman, that please enlighten us about WHO, EML, and ABRE classification and its importance in our neonatal practice.
2017, WHO classified 2017, WHO classified essential medicine list, and they classified into aware classification to avoid prescribing high antibiotic, unnecessary antibiotic. So they classified into basically three, and then updated into four. Aware is the excess group. Excess group is those antibiotic it can be first line or second line and can be used. So basically, they are narrow spectrum antibiotic with low potential to develop resistance. So excess group is usually every NICU should prescribe first or second line initially only. Then they go on to watch group. Watch group is those who have a greater potential to develop resistance and are a little broader spectrum than the access group, and they should be used with caution because they also have some toxicity also. Then there are a reserve group. Reserve group are like very high end antibiotic with a very broad spectrum, and they are, if develop resistant, the chance of developing resistance is very high, and we don't have anything beyond that. And then they, not to use antibiotic. They added one more group is not to use antibiotic. Those like the combination of two antibiotics. So these are the latest one. In fact, they have one for pediatrics also, for children also. I just taken a screenshot just to find out that what they do. This is a recent one updated in 2023, and they have a pediatric one also. So these are the excess antibiotic. They are usually everybody used in first and second line. They are penicillins and amikacins only. Then next slide, ma'am. This is the watch group where macrolide, second generation cephalosporin, third generation cephalosporin, they are broader spectrum, have high tendency to develop resistance. And then they are the third, they are macrolide, meropenem, cholesterol, all those drugs, which are, very, very broad spectrum and have, high tendency to develop resistance. And then the further is a not recommended drug. They are the combination of drug with a, overlapping spectrum, or if they cover the same antibiotic as the same antimicrobial, they are usually not recommended to be used. So we have to be aware of those things. The goal of this aware was to reduce the use of antibiotic, especially in the watch group and the reserve group. To whenever the excess group antibiotic is not available, we have to make them available, and then to help the countries or societies to track their antibiotic use. So they've started one GLASS is Global Antimicrobial Resistance Surveillance System to watch the antibiotic consumption and how they use them.
So I think this was one of the very important aspects. You made us aware of the AWARE program. So I think this is, so we talk about access, we talk about watch, and we talk about reserve. And I think this is a time that, we see that it is put in a day-to-day practice, which of course some of us have been doing it. But I think one of the best way of, making your juniors and everyone aware of this is to put it as a question in your exam paper. So that's how the students read, and the generations will, even at undergraduate level. So right from, it happens that if I ask my student, they might not be aware of this classification. So whatever is asked in the exam, they studied. So whatever are the most important topics, I used to tell my students that this is an open, this thing, you will get questions on infection control, KMC, lactation, and all those things. They are not glamorous, so they do not attract students' attention. So I think one of the most important topic is this, and as a seniors, we should give importance to this, and we have to even ask this in the exams. Now, this is just for, this, that whenever, I take rounds in the, this, before I start taking rounds, they have to tell me certain things, that how many KMC, how many hours, what is infection control. So I've given them a note, and unless they tell me that, the round doesn't start. So if then they feel that, these are the important things for the seniors, and then they will do it. So I think antibiotic stewardship is one of the topic to be managed like that. The next question. So we have limited time, but I think we are doing well. We still have about 20 minutes. So when we have spoken about this, how do we implement it in a healthcare facility? I will ask Swapnil to answer this.
So, how to plan a antibiotic stewardship program? Generally, we should have some kind of a set goal. I mean, what exactly what we want to do. So the goal has to be, the thing is that how much reduction of antibiotic usage we are planning to go for next, maybe a timeline, a 6 month or 1 year, that we have to set in our mind. And then we have to sensitize, we have to form a team. I mean, it is nothing but one of the quality improvement studies in which we can take it. So we have to form a team in which important persons like the clinician in charge, pharmacist, as well as microbiologist, infection control practice person, sister in charge. This has to be taken into consideration, and the job has to be allotted for everyone. There has to be someone who has to take audit for this thing. Now, after doing this thing, next slide, please. Then, for example, what we have done in a simple example of we want to reduce the use of vancomycin uses in an ICU, because mostly vancomycin generally it is rampantly being used, and for MRSA as well as enterococcus. Sometimes it is used for enterococcus also. But we want to reduce the usage of vancomycin. So we have targeted that these are number of the vancomycin usage in a month, and we want to decrease it by 20% for by next 6 months. So now we have to take down the data that how many are actually organism which culture positive babies who are sensitive to vancomycin. For just we are taking discussing the example, and how many have improved after starting culture negative and started improving after the vancomycin as well as a single drug. So now doing this all study, like getting the data, then educating the team, then again doing some kind of practices that only we will taper down to say, tapering down the antibiotic stage, and then monitoring what is the outcome. How are the newborns getting affected? Are there is the survival rate or what was the infection rate? Is it increasing? Now, if you show this thing to your unit that after doing this kind of maneuvers, we are able to get benefit of improved number of babies who are not getting sepsis, then the unit understands that what we are doing is the best. Slowly forming, next slide.
So this
Now,
is a SWOT
SWOT
analysis. Yeah.
So what we do in SWOT analysis, we generally that is a strength. What is our strength? What are the weakness? This is all quality improvement studies what we do, and then what are the opportunity and what are the threats. So strength generally once after doing this kind of session, we are getting so much excited that हमें करना है antibiotic stewardship program, but that has to be sustained. Now, secondly, that we should get records that culture positive kitne the, how many of antibiotic usage are there, then the data has to be genuine. So these are our strength, but what are the weakness? वो data सही में सही है कि नहीं है? Now these are the weakness. I means another thing is that कभी records there might be no medical records. So this we have to overcome. Another thing is that what opportunity we are having, we are opportunity that active implementation of an action plan, that is national action plan on antimicrobial resistance. Now increasing awareness, what these are the opportunity which we can teach. These are the strength is that what we have, and opportunity is what we can implement. So on usage, how much funding can be available? What kind of antibiotic upgradations, first line, what we have discussing, first line, second line, third line, basis that we can decide on basis of reports, what culture reports we get. And threats, अब senior ने बोलना करना है तो करना ही है. That kind of a thing has to be curtailed. कहीं तो we have to justify that we are doing, and the thing is that justification has to be written or documented, and that has to be analyzed at the end of the this kind of study period. This is all about how we can plan.
So thank you, Swapnil. We have only last 10-15 minutes. So I will ask Dr. Om Prakash next question that tell us 9 common areas. Everyone concentrate 9 common areas rather than only saying common areas. So tell us 9 areas where how can you improve your antibiotic prescribing?
So we should have a right patient. That means it's not just the identification of the patient, but should have a indicated reasons for starting antibiotic. We discuss about the risk factors. So we need to look at the high risk factors, and accordingly, if the baby is symptomatic, we should think of starting antibiotic. Second is right antibiotic based not just on your first line, second line as a documentation or theoretical part, but based on your flora that is available in your last 1 year's documentation, what is the sensitivity pattern of the antibiotic, and then accordingly we need to decide what is first line, second line, and third antibiotic. Then right combinations of antibiotic is also very important, because if you are using an irrational combination, there is high chances of development of resistance, and that is what we are landing in a present scenario. The dose has to be also appropriate, particularly in the extremely preterm babies where their ability to clearance the antibiotic, handle the antibiotic toxicity is very less. We need to adjust the dose. If there are underlying problems like a renal dysfunction, liver dysfunction, we need to adjust the right doses. And then right spacing between the doses of the antibiotics. Unfortunately, in Indian scenario, we don't do routine levels of amikacin or look at the peak or trough levels of vancomycin. So we don't have a titration of the dose, like next dose need to be adjusted 6 hours from 8 hours to 12 hours. We can't do that. So we are at high risk of development of all these sensory difference and other problems related to the antibiotics. So we need to make sure that we are using appropriate dosing of the antibiotic and appropriate interval of the antibiotics. And then going further, you need to make sure when we are starting antibiotic, we should stop the antibiotic in time. So that is right duration of course of antibiotics, as well as right review of the antibiotic course based on the culture available, and then stop the antibiotic early. The course of the antibiotics is very relevant, particularly if you have a deep seated infections. Don't think of changing from IV antibiotics to the oral antibiotics, because that will again increase the risk of infections. Multi-drug resistance is also very high. And then we should look at the toxicity on a regular basis. Certain antibiotics can cause difficulties in the preterm babies, and it should be a regular surveillance of a system, and that is how the system will be improved. Otherwise, we'll just continue the doses of antibiotic. Day 5 is finished, day 8 is finished, day 10 is finished. We should start antibiotic, and at the bottom we should write stop this antibiotic at 48 hours. So someone is going to reassure that the culture is seen and you are stopping antibiotic if the culture is sterile at 48 to 72 hours. So that should be a good way of surveillance when you are writing.
Thank you, Om Prakash. Now I'll ask Dr. Sahana that tell us the, for antimicrobial resistance, the key interventions. I would like you to limit your answer because we have
It
one
is
more
not
round.
only at the facility we have to curtail, so we have to take care of the community level also. So preventing, it's a comprehensive multi-sectoral approach in the healthcare and of course the agriculture and the public health. So what are the key strategies is, right, we have spoken about rational antibiotic use, and then prescribing guidelines should be there, which are evidence-based, and then avoid over-prescription and appropriate spectrum and correct dosage and duration. That has been emphasized already. Next, please. Yeah, judicious use of antibiotics, that is prolonged, just because many a times our students, they'll be waiting for culture, it will be more than 10 days. That's the thing we have to do in the antibiotics. This week also, many babies I had made it as a thing, hand hygiene audit and the antibiotic audit. We had to do so many things about that. And hand hygiene, of course, is the tailored therapy based on the local antibiogram. Depending on your own unit, it is not that Mumbai they are using, we cannot use that. So depending on our unit policy, then our antibiogram we have to do. And surveillance, isolation and monitoring. Because of these MDROs like MRSA allows early isolation and prevents the outbreak. AMR surveillance program has to be strict, and then antibiotic usage monitoring. It is every level, every unit, because we have 75 bedded NICU. So individuals are different everywhere. So I keep, as ma'am said, in my duty report, we have how many babies are eligible babies for KMC, how many are giving in each of the 4 places, because it's a humongous. At a time, we have 140 babies. Yesterday's is 139 babies in and around, because we have a dedicated KMC, 48 bedded KMC for that. And even the antibiotic individually, first level, second line, third line, who are all using in an outborn unit, inborn 1, inborn 2, and HRP. High risk babies who are, that is 1,500 and below. So least was in the, because I come under that less than 1,500, and the very 30% antibiotics, which are the first line was there. So we did this, and every day they have to show it in that, as ma'am said. And vaccination, of course, maternal vaccination, which prevents neonatal infections like influenza, pertussis, GBS, though we are not using, we are under, because we are not detecting that, maybe we are under using that. And of course, Covaxin, COVID vaccines. And environmental cleaning, disinfection protocols in the NICU, it should be robust, and fungal infection prevention. As we said, if you are using more antibiotic, fungal sepsis will be more. And antibiotic stewardship, it's a multidisciplinary teams and antibiotic audits, at global and policy levels, international collaborations, collaborate globally to share the data, resources, and strategies how to combat this AMR, and regulations of antibiotic sales, enforce strict regulation on over the counter. And I would like to say, yesterday I was listening to some IAP talk, like Kerala has become the first state to make it as an antibiotic smart hospital, So they have three-pronged thing. I just took a screenshot of that, because they have made as a no over the counter about the access drugs or to be more than 95%, and then no OTC antibiotics and antibiotic smart family health centers. Like goal is to make it as more than 95% of the OPD prescription into access groups, and over the counter they have banned in Kerala. Okay, and proper disposable of the unused and the expired drugs into one purple bag. This was the one which we can also start individually. Thank you, ma'am.
Okay, thank you. I would like Hemant to tell us about basic AMS intervention.
Basic aim intervention can be. So basic mnemonic for this, mind me. Mind me is like antimicrobial stewardship. We have to do like the antibiotic therapy should be guided with the cultures or microbiology, supported with inflammatory markers. So whenever possible, a culture should be obtained. Even if like you're changing antibiotic second day, a second culture will be, obtaining second culture will always help. Good amount of culture, like sometimes we take 0.5 ml. If you can, if a bigger baby 3 kg, if you can take culture, like volume of culture can be 2 ml also, two different site also, especially if you're taking from a central venous catheter. Indication of upgradation and starting antibiotic should be an evidence-based practice. It's not like that baby have a single episode of apnea or a feed intolerance and we initiate antibiotic or upgrade antibiotic. It should be tailored to a narrow spectrum of antibiotic, not meropenem to everybody. If the bug come back like ampicillin sensitive, so we should taper down to ampicillin. Appropriate dose that has been told before, and according to the site of the infection. Then minimize the duration of antibiotic. Like antibiotic, if like a central line is placed for like 1 month, we should not give antibiotic for 1 month. So early on sepsis is a gram positive sepsis, 7 to 10 days is enough. Gram negative sepsis, 10 to 14 days is enough. Meningitis, 21 days for gram negative, gram positive, sometimes 14 days also is enough. So duration is important, not to prolong the duration of antibiotic just for other reasons. And if possible, monotherapy. If possible, monotherapy. Single drug is equally effective like multiple drug. So that's the private like core active like intervention we can you do to optimize the use of antibiotic. And formulary restrictions is like some drugs should be used only after taking permission from a senior or a pre-authorization. There should be a audits and feedbacks what you are using. Like there should be a pharmacist who should be watching us what antibiotic we're using, how long we're using, and then they should give feedback also, and a computer surveillance. If we like a baby, we have to enter that this baby is having a bloodstream infection and there's a gram negative, gram positive. So the computer should beep that you are not supposed to use a meropenem in this child and not for a long time. And there should be automatic stop orders. Sometimes we like when we start antibiotic for a we have a Staph aureus in blood, and we on the first day we decide that there's no meningitis, we're going to stop antibiotic at 10 to 12 days. So when we there for 10 days, it automatically the nurses stop it. And nurses have a pretty vital role in this. They can prompt that, sir, we are going long on with this antibiotic. And then dose optimization. Sometimes we just overuse it. Like we have done a LP, there's no meningitis, still we go for a higher dose. or sometimes a lower dose also. Lower dose also equally, dangerous.
Yeah, sometimes we observe that the baby's weight has become now 1.7 kg, but antibiotics are as per 1.2 kg. So all these things, I think mind me is a very effective mnemonic, and you have brought out points very well. But with this, I think now the audience is little hypoglycemic. This is our last round of 4 questions. So I will request the answer in 1 or 2 lines, Swapnil. So tell us what are outcome indicators.
So outcome indicators like how much antibiotic matlab in a month you are using. You can just make it like as AUR, which is nothing but that is total number of total days of an antibiotic divided by total days of admissions divided into thousands. Another associated complication like monitoring number of NECs. Because of NEC is also one of the complication once you give higher antibiotic for prolonged duration. So how much NEC has been reduced, how much BPD has been reduced, now how what are the neurological outcomes and associated side effects. These are the primary outcome we generally can keep if we are planning for a antibiotic stewardship programs. Another thing, the proportion of units not exposed to antibiotics, this will give you a good feeling that हाँ चलो हमारे बच्चे without any antibiotics 1 किलो का बच्चा without any antibiotics घर चला गया. Now, other complications with the unit protocol in starting antibiotics, number of times antibiotic has been changed. What are the reasons they have been changed? Are there uniformity of a change? Now, how and if you form a policy that these are the policies and how many times the breach has been done. So these are the outcome indicators which we can generally utilize for planning a program.
So thank you. Next.
Yeah, these are all also things that is how early can be stopped. Matlab, if plan for duration, what we are generally discussing, how early can stop it. What are the ideal durations? How many times we have crossed it. What are the number of days in which we have used prolonged use of antibiotics.
So we know about the importance of quality in neonatal care. So Dr. Om Prakash, please tell us that what can we do at a facility level?
So this is like doing the groundwork. So it is very important to understand what are the core elements that we need to understand when we are thinking of improving doing for the antibiotic stewardship. So we need to know the staff, we need to educate them, we need to improve their awareness. We need to have multidisciplinary approach. So it's not just your own team members, but other team members, maybe pharmacists, maybe microbiologists. Even the leadership of the hospital are also involved in this process. We need to enhance infection prevention as well as control of the infection, find out the source of infection, maybe a labor room, or maybe the baby once coming to the units, maybe the common hand washing area may be the source of infection. We need to write the antibiotics as per the requirement in a proper dose, in a proper duration that we discussed already, and there should be ongoing surveillance of all this system. So this is going to be possible if you do a regular audit or you find out your quality indicators and then start implying. So how we can do that? There are different ways of doing. One of the ways doing the PDSA cycles, where we need to try to understand what are the problems. Like, see, most of the units have got their policies for different things. Hand washing policy is there. Your bundle care approach for the central lines is there. So all these policies are there, but we need to see how much policies are getting implemented. So the processes that we need to have major indicators, how much the policy is getting implemented. Otherwise, all the nurses, all the doctors are just going to tick mark hand washing done, just done. And how is your incidence? 100% hand washing in the NICU. But if you look at the groundwork, you will find many residents who are newly joined, they are not washing hands. In between, they are not using sanitizer. Many senior consultants who are saying antibiotic stewardship, they are saying, I'm not touching the baby, I'm just going to see the baby from a distance. They are not going to do hand washing. So this is how there will be fallacies in your system. So there are policies, but how much policies are getting implemented, that will be coming to put forth, will come in front of us when we do different analysis. And one of the method is doing this PDSA, and this will help to find out the policies, and then we re-imply the changes. These are the changes that we need to do, and then we need to review the studies in terms of what is the outcome of that change that has been done. So this is very important.
Thank you, Om Prakash. Now, madam, just tell us in few lines that what can be done at a community level. Next.
So the quality improvement, it is required even at the community level. The key interventions are education, then access to healthcare, and then rational use of antibiotics, especially the over-the-counter. Even the Ayush people are there now, they have the thing and they do not know much about that, and highest antibiotics are being used there. and even the community engagement using the leaders. Next. So maternal screening and prophylaxis for the interpartum prophylaxis, public education and awareness, maybe on the media, unnecessary things are there, the junk foods, etc. Maybe regarding antibiotic, we have to talk with some good leaders like Amitabh Bachchan or somebody, the latest people, whoever it is there. And yeah, I don't know. Access to clean water, that is WASH program is there from the government of India. Strengthen primary care and vaccination programs, of course, helps in reduction of the infection. Community-based antimicrobial stewardship programs like local monitoring, engage local leaders and influencers. Train the community pharmacists also, because over the counter is still, happening. Empower and train the community health workers. Then promote rational antibiotic use with the guidelines and audit and feedback.
Thank you. So there is no question that the quality improvement is required. So rather than asking Amitabh Bachchan, difficult to approach and difficult to convince, let's ask IAP and NNF that how can they help us with quality improvement?
That is required, ma'am, but people, the general public.
But here is the question of doctors more, that so let Hemant tell us how do we do that?
Bodies like NNF and IAP definitely have a role in, like, they can have strategies, like they can liaison with different bodies, they can engage with like other practitioners, especially veterinarians. They've been using a lot of antibiotic and then they're flushed into the sewer and then come back again, or the farmers also they give a lot of pesticides and antibiotic also. And these bodies can help, development of infrastructure. Training of the nurses is very important. They can have a, like this workshop itself, like we've been sensitized. They can sensitize the workforce to decrease the hospital infection by washing hands, and they can start like programs that or like the Kerala program the madam was telling, they can stop over the counter prescription of antibiotics when there's like less availability of drug. They will use less, or prescription from a standard doctors, or reserve antibiotic from somebody like a senior one, pre-authorization. Or in hospital also they can have committees which provide, like, which have accountability. Whenever you prescribe an antibiotic, especially a reserve antibiotic, you have to be accountable for it. They have to have a audit and feedback policy in the hospital that should be given to, like, forwarded to IAP or NNF, that we are using this much of antibiotic this month. Or after that, like education, madam told, like educating your juniors and telling them that yes, these antibiotics are not to be used. Or, and even in daily rounds we can ask which reserve antibiotic, how many reserve antibiotic are we using, and are we coming down on that. And then prevention is the key. If you do not prevent infection, then जितना मर्जी antibiotic बढ़ाते रहो, it's going to, and believe me, no, microbiome is going to lose the war with us. So basically, these are the key 7-8 intervention that we can do, like accurate identification, use of local antibiogram, avoid overlapping drugs, review cultures, right dose, right interval, monitor toxicity, and stop antibiotics.
I think that's wonderfully said. And I think all of us, seniors present here, it's our duty to train our juniors. So when the juniors come out, they are the future of India. So they probably, it's sometimes very difficult to change the people who are already in practice for 10, 15, 25 years. So newer generation with correct messages, I think it's a big thing. So this is one of the panel discussion where we have actually finished all the questions in time. So I would like all of you to say in one line, what is the, your take home message? One line.
Take home message is, ma'am, the basic hygiene has to improve, the antibiotic use has to come down. And that's the way we're going to stop antibiotic resistance.
Promote kangaroo mother care and breastfeeding. Think before you use.
We have to make ourselves as well as our juniors to understand that all things is not sepsis.
Yeah.
There is way beyond sepsis.
Yes, yes.
When you write the order of antibiotic, write the order of stopping antibiotics simultaneously. And I'm very sure the nurses follow it very sincerely than you and me reminding them.
So very important messages have come out. And I like the previous one. This sentence is very important, that investment in infection prevention is always pays the best dividends. The next. So this is, what we want to achieve, means all of us, and of course the government, to achieve this by 2030. So with currently this is as per SRS 20, and you can see what is the neonatal mortality, infant mortality, under 5 mortality, and what is expected in SDG goals, which has to be mortality less than 10, less than 12, but our government wants a single digit neonatal mortality. So if we have to achieve this, the next, which are the INAP goals next. So this is to attain the single digit neonatal mortality by 2030. By ending all preventable deaths, we have to work on antibiotic stewardship. And for individual state, this target is to be achieved by 2035. So with this, we come to end of this session. Thank you very much. I take this opportunity to thank all of you. All of you have done a very wonderful job and given very clear and crisp messages in time. And I really enjoyed moderating this session. Thank you very much. Yeah. 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 I'll give it to her. This is. Yeah. Yeah. All of 4 of them will. Yeah. No.
And we don't have blood culture positivity. So in this situation, how to go about the bonus study? It's very simple. I mean, we usually use blood pressure in this area. In the first area, we use ammonium lactose along with antihistamine or peptide. So we use 2 antibiotics. And in second, we use whatever comes to, whatever we can do to save the baby, just go hard about the antibiotics. How to keep the immunity?
Because mostly I get those kind of babies in which the baby is on, you name the antibiotic, Miro, colistin, amphotericin, tigecycline, and what else? Leoflux. 5 के बाद तुम्हारे पास बच्चा है and the baby has been referred with the diagnosis of neonatal sepsis. तो क्या करेंगे अभी हम रात babies come at around late night 11 o'clock baby आ गया, received a phone call, सर क्या एंटीबायोटिक दे, बोला अभी कुछ मत करो, सिर्फ ब्लड कल्चर भेजो और सीआरपी भेजो. So there is one other thing which we have not yet discussed, that is the rapid diagnosis of neonatal sepsis. So molecular studies which we, but it is a little bit costly, specifically in such kind of scenario in which you have to show the evidence to the parents, हाँ ये कर रहे हैं because ये है. So in that scenario, we do start with antibiotics. What antibiotics are going along? Wait for culture report to come, and then taper to the antibiotic, which may not be the rest of the antibiotic. Even single amikacin will continue. So this is the how in which we tackle with the monotherapy for such kind of babies. So we send PCR studies for this thing in a lot of private labs they are doing.
So there is sepsis panel is there. Yes, very right. So BioFire are PCR based tests. So they may pick up multiple parameters. So we need to see the cultures. See, cultures is one thing which may take some time, and the PCR will come faster than us. But the clinically also we need to correlate what we are handling with. So there are multiplex PCR, yeah, that is what we send. And in there are sepsis panel, if you specifically look for that, then you will get the common organism that we face in NICU settings. Yes. No, not here.
So along with them, they are also providing with the antibiotic, which are, if the organism is resistant to that, they are also providing that data.
That generally when we are giving antibiotics for there are risk factors in the mothers, and if the mother's culture report or her high vaginal swab at times is not available, you give the antibiotics
antibiotics which are against the vaginal flora of the mother. So that will include both positive and negative. That time you can't have monotherapy because when you are giving two, whichever. Now till today we are giving amoxicillin, clavulanic acid along with amikacin. So we are not giving ampicillin because I know in our institution ampicillin resistance is there. So we use amoxiclav along with amikacin. So that is one. Second important thing is that you have to know what is your unit flora is. Because many years back, whenever we used to have fungal infection, it was very rare. We used to start fluconazole. And then one of our DM students, when we did their thesis, this is identification we did. And we found out it was Candida glabrata. Probably that time we had heard this name for the first time, Candida glabrata. And it is genetically resistant to fluconazole. So these babies, to give fluconazole is giving like water. So you have to have, so your empirical antibiotics are based on your knowledge what is the prevalent organisms in your unit. Now, if you ask me the use of vancomycin, our unit is 0 because we don't get mRNA, we get gram-negative. But some other unit might have it. So having the knowledge of your environment is also important because your empirical antibiotics, you are, it's based on that. Sometimes when the patients come as outbound patients, you don't know. So you are giving as per your experience, but you will get the culture report and you will change the antibiotics as per that. That's why to have a unit protocol and knowledge about your own unit, what have you, this thing, that is very important. So I hope we have addressed both the questions of yours. Yeah.
Where is created immunity versus physical barriers provided by the like skin and acid. Acid. So immunity even if you fit my skin, I cannot be survived with my intact immunity. I am immunocompetent. For the neuronal care, like
When?
how you grade
When? You are asking when?
Yes, immunity.
When? At what gestation you are asking?
Intact skin with broken wings, like
I am not able to get the question. With like,
So see, so all these barriers are very important for us to prevent the infection. Particularly in the preterm babies, if you put any sticking, particularly if you look at the dynaplast, you put it for fixation of the ET tube, and the moment you break the barrier of the skin, you are at risk of infection. That is first thing that we need to understand. Now, second part of the immunity, in the preterm babies, their immunity system is not developed well because the maternal transfer of even IgG is also not enough for them to protect them. Now, third component, what you're looking for, the acid as a barrier, that is very important. Many units, particularly in the pediatric ICU, any patients come to them, the first medicine they write is Pantop, injection Pantop. So that should not be the policy in the neonatal unit. You increase the risk of sepsis, particularly fungal sepsis, if you are using any antacids like this. So you need to be very careful. There is a direct correlation between the use of Rantac and all these secondary sepsis for these babies. I hope you have. No doubt.
pH of the skin is between 4.2 to 4.5. So when even for these full-term normal newborns, when you are prescribing soaps for them for the bath, you have to prescribe low alkaline soap because if you don't use that, you are the nature whatever protection is given is gone. So it's not only for sick babies. It is for term whatever babies. So whatever given by the nature, we have to preserve, and that's how we have discussed about kangaroo mother care, breastfeeding, lactation management, which is again the nature, giving colostrum to the baby. So this is all nature's thing. The second thing that the preterm babies are basically described as immunologically inexperienced and immunologically incompetent. So we have to always keep in their mind. And when you talk to relatives, we tell them that the microorganisms actually walk through the skin. The skin is, the keratin is not developed. So when keratin is not developed, the skin is not, tough. And then the microorganisms can actually walk through this and the babies can get infection. So we have to see that whenever you are, even putting adhesives, you are putting appropriate adhesive and you're not putting it from this end to other end. So you have to use minimum adhesive, whichever for newborns, so that the breaking of the skin, which is related to adhesives or the medical devices, which is a terminology, medical device related skin injuries.
have to be minimum. And for this, you require quality initiative studies. And that is the way how you can convince your, now, not only about that, you get injuries with the nasal mask, you get injuries with the prawns. So all that, becomes the source of entry for the organism. So you require to answer yourself for every action what you take. Is it necessary and do it appropriately?
Certain drugs, they require infusion, especially this piperacillin, meropenem, like all those drugs. Like these drugs, if given or like especially in sick babies, if given over infusion of 3-4 hours, they have a better activity. And some drugs should be given in infusion because of the toxicity, like amicacin or a cholesterol.
Nowadays, government is trying a lot of information.
Yeah.
And they are unused.
Thank you very much, all of you. And thank you all of you for being here. 2:15.
Thank you. Yeah. Thank you. Thank you so much. It's always so nice to hear Ruchi Nanavati ma'am, and thank you all the panelists. It was wonderful, wonderful. Thank you. Thank you.
They are our students. These are students. These Kishore Gowda students. So that becomes a second and third generation income. Come, Tanushree is also with Vinay and Preeta who did from Kenya. This is the ripple effect. The panel was good.
Getting complicated. We have been doing it. Nowadays, now these things are coming, right?
हा बघा कसा आहे
हा तो
आहे ना ह्याला नका घेऊ ह्याला नको घेऊ. त्याला
जो आवाज उन्होंने माइक में नहीं बोला वो नहीं आएगा।
अच्छा
वो एडजस्ट कर लेना मैडम। ये तो डाल दी है।
ये बंद कर दो क्या
बंद कशी झाली ती
काय
ही
HDMI काढली का पाहिजे का
नाही मी विचारू
त्या हे बंद का करू
चार्जर
चार्जर
का हे बंद होतं?
हे आपको बंद होतो
बाबा डेंजर आहे
बंद करायचं नाही ना
चालू ठेव
नाही ना बंद करू का
हा त्याला बंद करा त्याला बंद करा. ही त्यांची केबल आहे ती आपली केबल आहे
एक आपले त्याच्यामध्ये हे त्यांचे